Without further ado, it's my pleasure to now introduce the neonatal therapist panel. This is an international group of clinicians that represent the disciplines of occupational therapy and speech-language pathology, and they're going to talk to you about neonatal therapists in action from a global perspective. So please welcome our next speakers, Dr. Deanna Gibbs, Janine Craig, Christy Gliniak, Annie Aloysius, and Emily Hills.
Good morning. Perfect. And we are representing all neonatal therapy disciplines, so physical therapy, occupational therapy, and speech-language pathology. I have the pleasure of introducing who we are, us. So first, I'd like to introduce Dr. Deanna Gibbs, who is the Director of Clinical Research for Infants and Children at Barts Health NHS Trust in London. She is an OT by training and has worked predominantly in acute pediatric and neonatal settings in Australia, Ireland, and the UK. She is a certified neonatal therapist and also certified in neonatal touch and massage. Her doctoral work explores parenting occupations. That is one of her passions that will show up in the literature in the NICU. Her postdoc research is focusing on the influence of parent psychological well-being on engagement in caregiving and self-efficacy in the NICU. Next, I'd like to introduce our esteemed Emily Hills, who is a clinical specialist neonatal OT at Imperial College Healthcare NHS Trust. She is also a certified neonatal therapist and has completed her MSc in Advanced Neonatal Studies at Southampton University. She is also NIDCAP certified and responsible for organizing and lecturing on the Family and Infant Neurodevelopmental Education, or the FINE program, in the UK. She's also a senior Brazelton trainer and certified to teach on the Newborn Behavioral Observation, or NBO, and also the NBAS. And then our wonderful Annie Aloysius. Did I say your last name right? I love that last name. Annie is a senior specialist neonatal speech and language pathologist with over 20 years of clinical experience in neonatal care in the UK. She's worked at Imperial College Healthcare NHS Trust since 1995, working at Hammersmith, St. Mary's, and Queen Charlotte's and Chelsea hospitals in neonatology to support parents and their infants in improving feeding and early communication outcomes. She is a qualified lactation consultant in IBCLC. She received that in 2010 with expertise in supporting lactation and breastfeeding for both our preterm infants and our sick newborns. She has numerous publications in the area of feeding, including book chapters. And then our lovely Christy Gliniak is a neonatal occupational therapist who currently lives in Spokane, Washington, but she is Canadian originally. And her passion is around advancing neuroprotective developmental care practice as a collaborative teamwork in the NICU. She actually graduated from the University of Alberta and worked at UCLA, which is in California. She is currently the lead neonatal therapist at Multicare Deaconess Hospital in Spokane, Washington, which is a level 3 NICU. And then she also helps support their collaborative quality initiatives. She is also a certified neonatal therapist, a developmental specialist through NAN, and is certified in neonatal touch and massage as well. And then she also additionally has her certified patient experience through the Barrel Institute. She is on the leadership team with the National Association of Neonatal Therapists, and her first passion, I can think probably to say, is as wife and the mother of her 2 precious children. And then I'm last. I'm the dinosaur of the group. I live in Metro Atlanta, although I was not born there. I'm the program director for a PhD program out of Santa Barbara, California, which is in infant and early childhood mental health and development. I am also a certified neonatal OT. I serve in leadership with the National Association of Neonatal Therapists. I work PRN at a level 3 NICU in Athens, Georgia, and I'm currently on the board of directors for the National Perinatal Association. I've been in practice for a little over 38 years now, Have my NIDCAP training under the tutelage of Heidi Alls. And then my first passion, I'm going to practice some of my Scottish, is as the parent of 6 children, and they are my first loves. So without further ado, here's Deanna.
Good morning. So the focus of what we want to cover off today is actually to promote really some discussion about what experience you have with neonatal therapists in your units and really what the contribution is that neonatal therapy will make to the multidisciplinary care team in the NICU. We are certainly aware from an international perspective that the provision of neonatal therapy is very varied between units, across regions and across countries. And in some cases it actually remains absent as well. How neonatal therapists function with MDTs across units will vary, and often that's about local resources, about government policy, and about availability of training. However, it's not always about policy and funding. Sometimes it's about lack of access to appropriately trained and skilled neonatal therapists. Sometimes it's about lack of awareness of therapy or neonatal unit managers about the potential contribution of neonatal therapy. And sometimes it literally is about where are the funding streams from when they're really struggling to actually fund nursing and other sort of physician and other caregiving roles in the NICU. How do we actually allocate streams for neonatal therapy funding? So as a group of international neonatal therapists who work across the UK and the US, as you've heard, what we hope to cover off today is really just to present an overview for you of neonatal therapy practice and sort of the current models of therapeutic approaches that we adopt, to spend a little bit of time to explore some of the variants that exist in terms of the international profile of neonatal therapy practice, and then to make it more interesting for you, present a series of sort of case-reflective conversations about 4 different types of babies that we might see in a neonatal unit, just to sort of help understand a little bit more about some of the reasoning that goes behind neonatal therapy practice that you will see in the NICU. Firstly, I'd just like to focus on what we're meaning by the term neonatal therapist today. We certainly recognise that in addition to medical and nursing expertise in the NICU, there is a wide range of allied health professionals who do contribute to the neonatal MDT. But in this presentation, we're focusing on the term neonatal therapist to mean occupational therapist, physical therapist, and speech and language therapist or speech-language pathologist, depending on which area you work. And as you can see from this definition, which comes from the National Association of Neonatal Therapists in the US, these 2 professions all contribute both to direct patient care in the NICU and also consultative services to high-risk infants. Some of you may remember that about a month ago we sent out a survey link because we were interested to actually understand from your perspectives what your contribution was as neonatal therapists in your units, or for other professions, what interactions or what you felt the contribution of neonatal therapy was in your unit. We had 25 respondents. I'm not sure if many of you here were some of those group, but as you can see, the vast majority of our respondents were from our hosts here in Portugal, so thank you very much for that. And unsurprisingly, because you are the biggest workforce in the neonatal setting, also the majority of our respondents were registered nurses or advanced neonatal nurse practitioners. What we wanted to ask, one of the things we wanted to ask was from your perspective, what you felt fitted within the domains of neonatal therapy practice. So you can see there on the left various types of constructs or areas in which neonatal therapists might intervene. And certainly 96% of you agreed that you had neonatal therapy as a contributing member to your neonatal team, and 75% of you felt that they probably had a role in all of these areas, though assessment of neuromotor performance was certainly the highest indicated area. Some of the additional areas that people commented in the free text was actually around provision of a profile to enhance feeding skills of infants, to provide splinting, and to provide education for the rest of the neonatal MDT, staff orientation, and to drive quality improvement initiatives. We were also interested in your unit or your region, and in general, which neonatal professional led on certain areas of practice. So we asked about 3 particular areas. Firstly, in relation to who leads in relation to pre-feeding, feeding development, and any instrumental swallowing assessments and interventions. And as you can see here, the large majority is led by nursing leadership, and 52% felt that neonatal therapy had a contributing role in that as well. We similarly asked your thoughts in relation to sensory motor development, again, led within nursing, a higher proportion of people, 64%, feeling that neonatal therapies potentially had a leadership role in that area. And then finally, in the much broader area around developmentally supportive care and the provision of family support, again, majority of people feeling led within the nursing leadership, and around 30% feeling that neonatal therapy had a leadership contribution to that area. So what these slides really demonstrate is the overlap of knowledge and skills, particularly between nursing and neonatal therapy. And that's actually often a really positive, because it can really enhance that collaborative relationship that we need to when we're really thinking about how we support infants and families in the NICU setting. The final question we asked was to try and unpick what some of the educational requirement variability is across the world. So we asked you, in your country or in your region, what is the minimum educational requirement a therapist needs to work in your setting? And that ranged, as you can see, from diploma through to master's, the majority being a bachelor level degree. So although a small sample, your responses were actually quite representative to some of the highlights of some of the issues that we often talk about in relation to neonatal therapy provision in terms of consistency of scope and practice internationally. And over the last 10 years, there has started to be significantly more international collaboration amongst neonatal therapists, particularly in the area of education and also in research practice. And so, people working together, given we are quite small professional groups in each of our countries working together, it gives us a lot more opportunity to share information and knowledge. However, it does become apparent that there is still quite a wide divergence across the globe in terms of what neonatal therapy has to offer and how it's supported. So, as we saw from the survey, the initial basic training to become a registered or licensed OT, PT or SLP will vary. Currently, although there are still people with diploma qualifications working in practice, the current requirement ranges anywhere from a bachelor degree to a clinical doctorate as a minimum educational requirement. Historically, one of the other issues we're faced is that the availability of specific therapy education for skills and techniques required to work in the neonatal setting have been very limited and often sort of clustered around certain international centres. But again, over the last 10 years, there's been a big shift in terms of the availability of therapy-specific training in terms of online training platforms by international teachers actually taking their programs abroad. And also actually, the way of global movement means that it's often a little easier for us to actually travel to other centres to access training as well. We also know that in some areas, but certainly not all, there have been robustly developed competency frameworks to ensure that any therapist who is commencing work in the neonatal setting either has or can be trained with clinical supervision and mentorship to develop the required specialist skills and knowledge to practice at that advanced level. And certainly one of the biggest areas of variability, which I'm sure is evident across all neonatal professions, that really impacts in terms of the staffing numbers and representation we have in the units is resources, so funding streams. One of the ways that, from an international perspective, the neonatal therapy body is really trying to address these elements of variability is the establishment of the Neonatal Therapy National Certification Board. So this board is based in the US, but it offers an international certification through which neonatal therapists can demonstrate that they've achieved a specific level of knowledge, education and experience to undertake advanced practice in the NICU. So now just to talk a little bit about how neonatal therapy has shifted over the years in terms of its contribution to the NICU. So like all aspects for neonatal care for all professions, over the 4 decades that NTs have been working in this area, there has been a complete shift in our practice approach. So initially therapy services were provided in a very traditional rehabilitative model. Infants tended to be referred to neonatal therapy with a very specific identified impairment, either related to their prematurity or other high-risk factors. and then therapists traditionally used a problem-based approach, which was designing and delivering intervention to try and mediate that impairment. However, like all professions in the neonatal space, we also undoubtedly benefited from Dr. Ows's publications around her synaptic theory of development, and obviously the ongoing wealth of research about the benefits of developmentally individualised care. And actually, as a result, generally all neonatal therapists would now or should now practice from a much more prehabilitative neuroprotective model of care. So what that actually means, generally therapists will be involved in the delivery of individualised developmentally supportive care as part of the neonatal MDT, and really aiming to support the infants and families developing capabilities and mediating the impact of the NICU admission. That we are involved in understanding and therapeutically supporting the experience for parents and their developing relationships with their infant, both also in relation to both perinatal and infant mental health factors. And also we can still continue to provide that early intervention approach for infants who have identified neurodevelopmental sequelae. We also acknowledge, obviously, that there is this huge overlap, though, and these approaches to care are also shared with other neonatal professionals in the NICU space. And so really it's about thinking that those different professional roles, while they may overlap, each of those professionals will also bring their unique lens and their unique sort of philosophy to joined up care around the infant and family. But it can also be helpful to think about what do neonatal therapists bring that's different to the neonatal MDT. And certainly one of the things that we often bring is the long-term perspective on infant and family outcomes. Therapists are often routinely involved in the provision of follow-up clinics or follow-up outpatient or paediatric outpatient services. So we have sort of first-hand knowledge and experience of these neurodevelopmental sequelae that these infants often experience. So we will have been involved in addressing long-term issues around neurobehavioural regulation, sensory processing, cognition, communication, attention, executive functioning, respiratory functioning, motor development, all activities of daily living. Through infancy, childhood, adolescence, and often into adulthood. So we're often the people in the space who can really have a good sense of what is happening for that moment, for that baby, what is the potential impact on this baby and their family in the longer term. I think the other thing to bring out is that, yes, as neonatal therapists, we all have a range of common skills and knowledge, but that each profession will bring to that delivery of care a uniqueness to their profession as well, and really by having all three therapy professions represented in the neonatal unit really sort of enhances the care that we can provide to those families. One of the things I thought would be interesting to think about is just sort of the often discussion in the literature about whether or not neonatal therapy is an established area of practice or an emerging area of practice. Often, certainly in some centres, it's still sort of considered very new, and often, neonatal therapy is not often considered as part of that group. So I thought it would just be interesting to briefly look at some of the history around how long neonatal therapists have been working in the unit. And certainly in the US, which is the earliest published sort of professional references we have, we know that from a physical therapy and an occupational therapy provision input, neonatal therapists have been working in the NICU setting since the 1970s and have had professional sort of competency or professional position papers published from 1989 and 1993 respectively. In the US context, speech-language pathology was a later addition, but they have had a recognised contribution since the 1990s, with their position papers being published in early 2000s. So I would argue that it is an established area of practice, however, possibly not in every region and country. We also wanted to just share with you from the published data what we know neonatal therapists are doing across the world. And this is the sort of key areas where we have published available data. That's not to say that these are the only areas where neonatal therapists work. So we're going to briefly look at each of those areas. And the following slides have quite a lot of data and information on, which I'm not going to go through, so it's more there for your reference. But we'll just pull out a couple of key highlights from them. So firstly in the US, I know this is quite a busy slide. So the most recent data we have is from a 2016 practice analysis that was done with between just over 450 neonatal therapists. And generally, we're looking at the fact that respondents generally had high levels of education. So as you can see there, over 50% of people had doctoral degrees. The majority of them actually had a minimum of 3 years, if not more years of practice in the NICU setting. And in terms of the areas of practice, you can see on the left hand of the bar chart there, neonatal therapists were involved in. You can see they're actually involved in many of those settings, but it was actually the implementation of developmentally supportive care and parent education that was some of the most highly responded to. And within the United States, if you're working in that setting, each of the 3 professional bodies also has published position statements or competency standards outlining the contribution of neonatal therapy in their region. In terms of Canada, they've done 2 national surveys, the most recent of which was published at the end of last year, and they surveyed all 31 NICUs in Canada, and they had responses from 25 of those, of which 19 units responded to saying they employed neonatal therapists. There seemed to be more of a transdisciplinary model used in Canada, so half of those units reported only employing 1 discipline. But as you can see, again, they generally had, at least half-time roles in the units. Huge amount of experience again. The majority of people had over 10 years experience of working in that setting. And again, they had sort of diagnostic groups, sort of fairly typical. So infants who had identified CNS disorders, prematurity syndromes, and respiratory, cardiac, or orthopedic concerns. In relation to Europe, and I know UK is now technically not longer part of Europe, but we'll be friends for the moment. We actually don't have data from Europe. So although the SEEN group have actually conducted a number of international surveys across 11 different European countries to look at variation in practice, those surveys haven't yet drilled down to actually neonatal therapy contribution. We do have information from England. We don't yet have solid data. There is a national survey being conducted across England at the moment to identify all of the professional representation across all of the units. But in 2018, there was a transformation of care review conducted for neonatal services. And as a result of that, we have now service specifications written for staffing for each of the 3 professions, and each of the 3 professional bodies, so the relevant physio, OT, and speech and language therapy bodies also have either published guidelines or competency statements in relation to provision. All 3 disciplines are also recognised in the British Association of Perinatal Medicine recommendations for service specifications for hospital staffing for neonatal care. And then finally, in Australia and New Zealand, we had a publication a few years ago which surveyed every neonatal unit and special care nursery across Australia and New Zealand, and they were particularly looking at neurodevelopmental allied health contribution. And they got responses from all 100% of NICUs and about 60% of the nurseries. And 96% of the NICUs had allied health neurodevelopmental representation, with physiotherapy and speech and language pathology being the most commonly represented. Interestingly, because the focus of this paper was about who conducted neurobehavioural assessments, and they identified that in the NICU setting that was most often a physiotherapist, but actually in the special care nursery that was most often a doctor. And then just to finish off our sort of roundup of what's in the literature, Janine Craig and Catherine Smith from the US, you may have seen just published last month, or January I think it was, this publication in the Journal of Perinatology, really looking at again the what neonatal therapy contribution is and its sort of elemental role in the delivery of neuroprotective care. So they identify obviously that interventions provided by neonatal therapists are focusing on optimising long-term development, preventing adverse neurodevelopmental sequelae, nurturing the family and infant relationship. And they also identify, as in your survey, the contribution of education needs that neonatal therapists can provide both to the NICU team and the family. For those of you working in the US setting, and I think even for those of us working outside of the US setting, this paper is really interesting because they have gone through and identified the neonatal therapy contribution and recommendations for staffing at each of the 4 levels of neonatal care in accordance with the American Academy of Pediatrics. Okay, and then the final section I want to talk to before we get to hear from everyone else is really about the delivery of family-centred care or family-integrated care, which we started to hear quite a lot about yesterday. And it really does seem to be a growing contribution of neonatal therapy in this setting as well. Certainly in the UK context, there is a growing number of neonatal therapists who are either leading or part of leadership groups to actually implement and embed family integrated care into the neonatal settings. And actually there is a funding stream coming online within England where they're actually going to be employing new posts which are purely around the delivery of family integrated care, and neonatal therapists have been highlighted as professions appropriate to lead in those roles. And we just want to share with you now what that looks like in terms of how different might family integrated care look compared to some of the more traditional models of caregiving. So at Imperial College Healthcare Trust, where Annie and Emily work, a multidisciplinary team has been embedding a FICare approach for the last 3 years. And one of the more transformative aspects of their approach has been to instigate the inclusion of family-led ward rounds, which we're going to share a brief clip for you. If it works.
So this is my son Michael, and I'm Ashley, his mom. He was born, yes, buddy, what? You done? Are you done? He was born at 24 weeks, so I went into labor at 23 weeks and 6 days. And yes, Michael was ventilated straight away, of course. His first 28 days were, he threw everything at us. We tried to extubate him twice. One time he came off for about 6 days, and then he had to go back on. And then I believe we were about January 8th that we were able to extubate him for the, hopefully, final time. And since he's really gone from stride to stride, he's had a couple of wobbles of what we thought could have been, he had 2 infections in that first month. But after that first month, a couple of wobbles that we thought might be infection, but it turned out both times he was just pretty tired. He was just telling us he was tired. He came off of high flow last week, and he spent about 4 or 5 days on 10 cc's, so he was doing really well. The last couple of days we've had to bring that back up. He was telling us that he was pretty exhausted. And we did start antibiotics on Monday, thinking that he might have an infection. He wasn't just tired, but he was quite lethargic. But since then, he's actually been doing okay. And this morning, he seems to have his personality back.
Fantastic.
How's he doing with feeding? So, feeding, he was really showing signs quite early that he wanted to try the breast. So if we're at 34 weeks now, it was about 31 weeks that he was really starting to lip smack and look around during feed time, and that was when he was still on 2 hourly feeds. It was only last week that we took him to 3 hourly feeds, and now he's showing those signs even more. So at the moment what we do is we put him on at his feeding time, thinking that he might not be getting that much and he's just playing around. But then every now and then he surprises us. So last Monday he was on the breast for 40 minutes and we didn't do any of the feed because he was really going for it for most of that time. And actually this morning, although he's falling asleep now, he was really going for it as well. So I think it's kind of the times he has the energy.
So you're just starting to reduce top-ups when you think he's showing signs. And has someone gone through those signs of milk transfer with you and showed you the top-up chart? No. So maybe we could do that today.
That would be great.
Just go through and support, so you know how well he's doing and how much.
That would be great, Angie. Thank you.
Yeah.
Okay, so I think if nothing else, that video certainly shows you that parents are the experts in their infant's care, and often we just don't give them the space to really enable them to fill that role. So we're now going to move into the case discussions or case conversations. So again, these are just really to sort of share our thinking out loud about how often we'd plan our care around individual infants in the NICU. So I'm going to hand over to Emily and Annie.
Okay, so morning Annie. I have just been up to the neonatal unit and I have met Ned's parents, Rose and Patrick, And they spent a lot of time just going through the birth history with me and a little bit about who Ned was. And Ned was born at 41 weeks and is their first baby, and the pregnancy was really uneventful, but he was delivered by emergency C-section due to cord prolapse, and he had head entrapment for about 8 minutes. Anyway, Patrick says loads of people entered the room. It was really overwhelming. He said that Rose held her son for a little bit and then was whisked up to the neonatal unit. They've got having an MRI at the end of the week, but they are super concerned about absolutely everything. This one. Oh, look at this. Okay, so they're super concerned about everything. Mum is really keen to breastfeed. There are still loads of oral secretions. He's being suctioned a lot. He's tube fed. Therapeutic hypothermia finished about 2 days ago. Do you have any time to come and see them today?
So it sounds like they've been very traumatised by his birth, but it's great to hear they're already having skin to skin. And there's a real opportunity for them to get to know Ned, and it supports that early interaction. It would be great if they can start talking and singing to him, and I'll make sure they know just how helpful and important this is to developing that close and loving relationship and supporting bonding. Oxytocin stimulated by that skin to skin will also help mum's lactation, and I'm happy to go through an expressing assessment with mum and make sure her expressing gets off to a really good start. If she can get a good milk supply established, it'll really help her breastfeed if it's possible. And in the meantime, he's getting all the benefits of her milk through his tube.
Okay, that's great. So I will also go and talk to them about sensory systems and different activities to support his development. We can go through the benefits of massage, we can go through gentle movements, positive taste and smell. I'll go down and get some of the children's books so that both Rose and Patrick have got something to read to him, and we will definitely try and promote a bit more natural light rather than these overhead lights.
So supporting taste and smell and encouraging positive oral experience would be really good, especially if he's needing lots of suctioning and his secretions indicate that he might not be swallowing very well. It'd be really great to show Rose and Patrick how to do his mouth care with mum's express milk, and that'll support taste and smell, and also see how he responds in terms of tongue movements and sucking and swallowing. We really need to counter all the negative oral stimulation he's getting with positive opportunities to see what he is able to do and to avoid him getting orally aversive.
Fantastic. And I plan to go and do the NBO, so the newborn behavioural observation, with Ned and his parents, so that together we can really learn what a unique little person he is, and then also find out the areas he finds challenging. And as you know, the NBO is such a great relationship building tool that will really highlight his skills and his strengths and and his dislikes. So I think it's really important that we spend time together, learn about Ned's behaviours, so that together we can really understand him. And I will also go and do the practical assessment of general movements, just to determine what Ned's movement skills are like. We can then support the family with different positions of play to promote optimal development and variability of movement patterns.
Given his difficult start and potential brain injury and concerns about swallowing secretions, we will need to assess his oral feeding to see how he presents neurologically, and we need to know if he can protect his airway from aspiration with effective gag or cough and look at the safety of his swallowing. But we'll do this when he's having his oral cares and support him with whatever he's able to do in terms of his oral abilities to make sure we build on skills that he does have. Depending on his skills, we can start to encourage non-nutritive sucking, and maybe he can start to go to mum's breast after she's pumped.
Okay, so he will definitely be part of our neurodevelopmental follow-up clinic. So we're going to see him for regular periods throughout the first 2 years of life. However, shall we meet regularly to discuss what community follow-up he needs, if any, from OT, PT and speech?
This one working?
Okay, so Christy and I are now going to discuss Sarah. As you can see, she's an infant who was born at 24 weeks post-menstrual age, and she's now 27 weeks, corrected and receiving respiratory support via CPAP. The problem or the issue for Sarah's parents is they would really like to be present as much as possible, but they've got an older child, they live interstate from their families, they don't have a lot of local support options for childcare. So they don't find it as easy to be as present as much as they would like in the unit, and they're quite apprehensive about causing Sarah harm with their care. So Christy, I've just been seeing Sarah and her parents this morning and wanted to see if you had some ideas. Over the last 2 weeks, we've been really trying to work on helping them start to understand her neurobehavioral regulation and her cues, and how they can respond to those cues in their interactions with Sarah. It has been going well, but they're quite apprehensive about her cues and working out how best to respond to her. And I was wondering if you had any specific resources or something that we might be able to try with them.
A matter of fact, I do, Emily. I just went to a recent conference and listened to a phenomenal lecture by Dr. Roberta Pineda and her students from Washington University in St. Louis, Missouri. And they, in the OT NICU lab that they have there, they've done a tremendous amount of research on the area of sensory experiences and developmental outcomes. And as they went through their research, they came to find that most NICU staff are well aware of the benefits of sensory stimulation. However, they were very inconsistent in its delivery and the timing and dosing of the interventions. So over the course of the next 4 to 5 years, they compiled all this data and they came up with a program called the SENSE program.
Okay, I think I remember this paper, and some of you may as well, because this caused quite a lot of discussion at the time, didn't it? Because conversely to what they thought, they were doing a study where they looked at the difference in infant outcomes between single family rooms and open bays. And conversely to what they thought, they found that the babies who were cared for in the open bay setting had better language outcomes compared to the single family rooms. And when they thought about that, they sort of reflected that their local parent population and demographics meant that their parents weren't present very much. And so that the babies being cared for in the single family rooms often went for long periods with very limited language or auditory exposure, and they sort of thought that might have been an impact on their language outcomes. Is that the paper you're referring to?
That is exactly the one, and it was a fascinating discovery. So they went on to research a bit more, and they put together some developmental guidelines that they termed the SENSE program, SENSE standing for supporting and enhancing NICU sensory experiences, SENSE. And so the goal of this particular program is to empower parents. It's designed for parents, and it puts together a dosing and timing of developmental stimuli so that it is supportive of their age.
Yeah, I think that will probably be quite helpful because we've been working together, as I said, to help them become more attuned to her cues. And, you know, Sarah herself is currently really working hard on her autonomic and motor regulation. And she needs a lot of sensitive pacing and two-person caregiving during her cares. And so they're gradually becoming more confident in how they can be engaged in providing that nurturing support for Sarah. But I also think they're still really struggling to feel that there's a place for them at the cot side. And from memory, the SENSE program is very parent-oriented. Is that right?
That's right. It involves the interventions themselves involve evidence-based approaches that include infant massage, skin-to-skin, holding, rocking, and auditory stimulation. So what they did was they used the literature and the research that they compiled and made specific guidelines that incorporate, as you can see here, tactile, auditory, olfactory, vestibular, and visual and kinesthetic senses. So it kind of gives a guide that is specific to the age of the baby. And in this case, Sarah is a 27-weeker. So here's an example. And there's handouts and some really lovely pictures in there that they can follow along to make sure that it's appropriate. What we have to really keep in mind, though, is this is not prescriptive. It's really important that the guiding professional that implements the SENSE program takes into consideration the competencies and the limitations of the baby so that the homework that the family's doing with the infant remains very supportive.
I think this would really work as a nice adjunct to how the team have been supporting her parents. So we could look together about how we identify Sarah's strengths and vulnerabilities and ascertain which of these, and even at which times of day or during the shift, that she shows us she's actually ready to engage in these activities with them. I think the other focus on the SENSE program in terms of the importance of parent touch, voice and scent will be really helpful for us to think about how we can support her parents, possibly with something like the Snuggle Doll, so they can still feel a closeness to Sarah even when they're not able to be physically present.
And you know, that's something that is a common thing in my unit, where families aren't able to be as close by. So in our unit and in others, they are implementing the SENSE program using students or cuddle team trained volunteers to provide the stimulation when parents can't be there.
Yeah, I mean, I think that will help because they do really struggle with not being able to be present as much as they'd like. And I think if we particularly use it in a way where we can sit with Sarah's parents and together they can identify the strategies and support needs that Sarah seems to need and appreciate during caregiving, certain procedures, and even to protect her sleep, that they can then share with the wider neonatal MDT about how they would like Sarah to be cared for when they can't be there. So thank you.
I hope they would feel better. Yes.
So now we're going to hand over to Emily and Janine.
Sorry. Okay, right, okay.
So Emily and I are going to present a little discussion about neonatal pain and education, and kind of holding ourselves up in how to get information across to one another. So our
Okay.
discussion about pain.
So, morning, Janine.
Good morning, Emily.
I've just been up to the neonatal unit, and it was kind of a weird experience. So, one of our new doctors was about to do cannulate little Mohammed's left hand. And you know Mohammed, he's the little 27-weeker sleeping in the left-hand side of the room.
Yeah.
Anyway, I went up to the doctor and I was like, "Would you like some help?" And he said, no, I've got this. And I was like, yeah, I know you've got this, but I'm not sure about Mohammed. Anyway, so together we managed to settle Mohammed. We popped him on his side. We wrapped him in the muslin that smelt of his mother. We gave him a little bit of EBM on his dummy, and the whole experience was so much better. But it just got me thinking, maybe we should be doing some education and training sessions for our families and our staff.
Oh, that's a really great idea. In fact, one of the nurses in my unit just went to a seminar on neonatal pain, and so she and I just 2 weeks ago did a whole unit update on pain. And it's really interesting because she's been practicing for quite a while, but we both kind of reflected that the knowledge and information about neonatal pain has evolved so much over the last number of years, and the bottom line is none of us want our babies to be in pain, but we have to be able to support them. And because things are different now than what we knew, we really have some responsibility about education. But I was really appreciative that she asked me to participate with the education, because one of the messages in the webinar was about how to work collaboratively. And I know your experience is the same, but not always, just like you said with little Muhammad. We don't always get an opportunity to do like two-person caregiving, et cetera. So anyway, some of the messages that she shared in that in our little unit update, and I'll be happy to pull the articles that we used for that, was we talked about really what is pain. Because what we know is that literally just about everything that we do in the unit today puts our infants at risk for experiencing pain, and none of us want our babies to hurt. But she really talked about what pain is, really how to recognize our infant cues about what pain looks like, how to consider what pain assessments we're utilizing, and then also, which of course I loved because I'm a little biased in this space, but how the use of neonatal therapists can help in supporting the caregiving during painful procedures, which is exactly what you're talking about. But you know, one of the things that's really missing, Emily, is how to appreciate the pain that our parents are experiencing. And I know that, you know, our lived experiences kind of inform what we do today, and it just makes me think back on when my oldest daughter was, she was about 4, and was in the hospital, and they needed to give her an IV. And they took her away from me, out of the hospital room, to start her IV. And I remember hearing her scream from the other side of the door. Like, it makes me cry thinking about it now. That was 32 years ago, 32 years ago, and I still have a really stressful response from that. And so, moving forward, I would never let somebody take my child away and do a painful procedure without them sitting in my arms or me trying to comfort them. And so why would we not let parents do the same thing in the NICU? Why would we not help support parents in supporting their children? And not every parent's going to want to be able to do that. But I think the thing is to give them the choice, right?
Right, I agree totally. And I think we need to do everything we can to support parents know what they can do to comfort their baby. And I think parents, they know when their baby's in pain, and you have an instinctive desire to want to do something about it. And I think one of the worst things we can do is to assume that someone doesn't want to be there. And sometimes we've had some really kind, well-meaning members of our team go to the parent, look, you're not going to want to see that, go and have a coffee and come back afterwards. And we can't make that judgment for someone. We have to individualize it, and we have to ask.
Yep, absolutely. And I think also in the NICU, we need to feel empowered as staff to be able to support parents, but we also need to be supported ourselves. I was mentioning that yesterday. We need as staff to feel like we have support as well, because we all know that sometimes the system rules really keep us from being able to do the kind of care that we want to, and really the kind of care that's evidenced already. And so I guess I feel like we can't really ignore the evidence anymore. We just can't. We have to pay attention to it. I was looking at some of the literature that my nurse friend had from her webinar, and some of the themes that emerged for her were that communication needs to be within the treatment team. So there needs to be communication. We need to all be thinking along the same lines. And that also helps to serve as a kind of a strategy to remove barriers from the things that we want to do. Another theme that was evident was promoting the nurse-physician collaboration on recommendations. So in our unit, the nurses and the physicians work a lot together. And what I know also is that the collaboration with neonatal therapists, as you've seen, would also help elevate the support for our work together. And I think, I reflect back on last year when we were in Bruges, and that beautiful video from Madrid of kangaroo care and all the painful procedures that were done skin to skin. I mean, I've never seen an eye exam done on a parent before, and it was just a beautiful thing, right?
Right. So there are loads of parent resources out there. You've got Dr. Harrison's Be Sweet to Me little YouTube clip. You've got Linda Frank's handout on comforting your baby. You've got the IFDC app, which includes bits on pain management. So what I think we should do is to have a supper club where we have really great food, and we have nice peer support with the parents, and we have an education session on pain management, and then we do it the same again next week for all the staff.
I love that idea. In fact, you can do one in the UK. I'll do one in Atlanta, and then we could even do a Zoom and do some cross the pond stuff, right?
There we go, winning it live.
That's awesome.
So this is another professional conversation between OT and SLT that we've kind of had across the pond too, so we just want to share some of our thoughts with you.
Hey Annie, it's Christy. I'm calling from Spokane, Washington. Remember we met at the conference last year. I'm reaching out because I remember that we had a conversation that your babies are going home at about 36 weeks and predominantly breastfeeding, and we're in the process of revamping our procedures and guidelines about initiating and progressing oral feeding, and I wondered if maybe I could get some tips from you.
So yeah, on average, our babies are fully orally feeding and ready to go home at about that time. And we see it very much as a journey that involves focusing, more than just focusing on weight and gestational age at discharge.
So feeding is really a relationship that starts as soon as a baby's admitted in the neonatal care, and it begins with parents starting to get to know them and be involved in their care. So working as a whole team on projects to implement, let's just go back to, there we go. So working as a whole team on projects to implement our integrated family delivered care work, and also working towards achieving our UNICEF baby-friendly standards have really helped to underpin some of the key cultural and practical changes we've needed as a whole team to achieve this. So the UNICEF standards are about more than just supporting breastfeeding, it's also parents as partners in care and developing close and loving relationships. Now, probably about 70% of our babies are going home exclusively breastfeeding, and part of being able to send them home so early is that they know their baby better than anyone, and they've been involved and confident in their baby's care and handling right from the start. And integrated family delivered care has really helped with that, and there's lots of resources on our website. We've got our free to download parent app as well, and we published some of our results last year in archives if you're interested in reading more.
Yes, I think one of the challenges that we're having could be related to the altitude, the difference. I know in Spokane it's about 578 meters above sea level, and you're at about 11 meters above sea level. So with our feeding progression, we have a higher rate of BPD. And so in response to that, our neonatologists have been using more of a prolonged CPAP use to try and protect and enhance lung development over time. So that poses quite a challenge for us therapists and nurses when we're initiating oral feeding when babies are on CPAP for a really long time, because some of the work that is in the literature by Dr. Louisa Ferrara and her team indicate that there's a higher risk of laryngeal penetration and tracheal aspiration if you're feeding on continuous positive airway pressure. So what we did as a team is we kind of compiled a quality improvement project to see if we could work together and find a way to bridge this gap when babies are on CPAP longer, and to still have a developmentally appropriate progression. So we were able to get this device called an end trainer. I'll show you here. It's this little device that has a pneumatic component on the bottom, hooked to a computer, and it provides two methods of support to our team. One is an assessment mode. You can see this little sweetheart of a baby has his pacifier, and he is having an assessment. And you can see in the bottom right corner here of an example of a strip from the assessment of the end trainer. So there's just some little squiggles is what we often see at 31 weeks, some disorganized sucking bursts here in the middle strip, and then a very nice organized strip on the bottom is what we're looking for when we see a baby who is respiratorily challenged, and but over the course of the time establishes this type of pattern, and we know that they're more ready to transition to a nutritive form of feeding. We've decided to tackle this small population of babies that are under 31 weeks and under 1,500 grams, because those are the ones that we're having a harder time getting to full oral feeds. And so what was really exciting is that we were able to reduce our length of feeding, time to full oral feeds by about a week. But mostly what the best part of this program was we were able to engage families. So the therapy component of this device provides little pulsations, 5 little pulses through the pacifier. There's no squirting or anything like that. And then a 2-second pause. So this pattern of sucking that's used early on, we're hoping that would establish the pattern for when they are ready to feed. And parents are the one that are doing this intervention while they're holding their babies, while they're having their tube feeding, and while they're getting some tastes of breast milk during the time. So of course we don't want to replace kangaroo care, because we're doing that and trying to do some exploration at breast, but we're using this device to engage families and have the staff on board to think about a pre-feeding program before we move to oral feeding.
Yeah, the fact your babies stay on CPAP for longer because of altitude really does make feeding more of a challenge for you. I think it really helps to shift focus of feeding from thinking about feeding as a thing that babies do once they're stable and getting ready for home, to see it more as an experience and a journey that can start from day one. So we really try and see it as something that starts with our delivery room cuddles, and that bond that you develop between mother and her baby, and then supporting her to express colostrum and give it orally to her baby within a few hours of her baby being born. So I really see breast milk as that thread that ties mums and babies together, so she can do her mouth care with it, be involved in tube feeding, spend time in skin to skin, developing that taste and smell and positive touch, and all in an environment of oxytocin that nurtures and builds that close and loving bond between them. And being tuned into each other like this really enables mum to know and respond to her baby's cues and look for feeding readiness. So if we then follow their lead when they're ready, it builds their confidence and responsiveness of how mum feeds her baby. So actually maybe more breastfeeding would help.
I think that might be a great idea. We're a little behind in that area. The article that I mentioned by Dr. Ferrara, here is the reference to that. What's really interesting that we have to keep in mind is that this particular evaluation was done in bottle-fed babies and not on breastfed babies. And so what's really cool in the research that's coming up is the use of fiber optic endoscopic evaluation of swallowing, or FEES. And this preliminary data is quite interesting because they're finding that babies are coordinating, as many of us guessed, coordinating better at the breast than they are with the bottle. And what I think is going to be interesting to find out over time, that we can document that. But we don't want to get so black and white, right? We want to make sure that we really dial into the baby's cues and really follow their lead when it comes to their response to breastfeeding, because some infants at that young age can tolerate some breast trials, even when they are on respiratory support.
Yeah, this is what we see in clinical practice too, that breast and bottle feeding are really different skill sets. But it's still a myth that we need to dispel, is that it's easier to bottle feed a baby and it'll get them home quicker. Actually, we find the reverse to be true, that bottle feeding needs a lot more external support with coordination and pacing and different teats and flow rates and careful positioning and oxygen. And actually, it's easy to override their cues and get feeding really out of sync with the baby's abilities. It feels sometimes like we're doing feeding to the baby rather than it being an interaction with the baby.
Right, and another tool that we've been using is the infant-driven feeding scales, so that we can frame our conversations about our documentation and how we're responding to one another, and how the baby is showing readiness cues or progressing in the quality of their feeding. And I think that that's something that has helped us get a little bit more in touch with the baby's needs, as opposed to being so stuck in the regimented NICU timing and volumes and all of those kind of things. Although we have more work to do in that area, I think this is a really nice place to start when we combine this this tool with the end trainer to get babies feeding more safely and in a developmental supportive way.
So it's great to talk through and compare practices and know there are similarities and differences, things to share, things to learn. And it really seems that no two places are ever going to be exactly the same. In the same way as feeding is an interaction and a dialogue, and there's many factors to consider, and no one way is perfect. No two infants or families are even the same. So what I think we both love about being involved with feeding is it's not just about assessing sucking and swallowing. It's about relationships, and a privilege to witness this beautiful bond and interaction and take time to be present and notice with parents the joys in their infants' abilities and validate their contribution. And those parts of the feeding relationships will last a lifetime.
Absolutely, and I think that I love the term in a paper I read about the internal working model. So really, we can feel good about feeding babies, but it's really not our job when the baby's at home. We have to make sure that decision tree and practice and support families while they're available, so that they can really feel confident when they leave out our NICU doors. So thank you. So that's the last vignette. You want to introduce the video?
Okay, so just to summarise, which is a little bit by me and then some by some other people, as you just wanted to do today was to start some discussion and to have some reflection about really all the overwhelming evidence we now have about the comprehensive neurodevelopmental care model and the various different roles professions can play within that obviously does lead to improved outcomes for infants and families in the NICU. But also to recognise that the provision of neonatal therapy is an advanced area of practice. So really thinking about the skill set and level of education and knowledge that you have in terms of the therapist providing care within your
Is about nearly 1 standard deviation of 15 IQ points. Yeah? You find exactly the same difference in the very preterm children. Can you see this? They don't interact, but what you find is they add up. So if you're very preterm, you're 15 points down. And then you are also of low social class, it's another 15 points down. They add up, you're 30 points down. So there's a huge additive effect of SES. And we do know that very preterm birth does occur more frequently in lower SES and partly in the highest SES because of fertility treatment. Yeah? So so you have got a very clear additive effect. So in a way, the effect of taking a kid, if I would adopt a kid from a higher social class into the lower social class, is the same intervention as if I would deliver it 9 weeks early. Okay? So just to put it in perspective. So the next question is, how does parenting, could it make a difference? And we observed parenting in the neonatal unit was rated, but we videotaped them at 6 and 8 years of age, and we looked here at 6 years of age at the sensitive of parenting. And we found a very interesting effect. So we call the full-term children their dandelions. Yeah? So most of these kids, you can plant them wherever you want. They grow like dandelions, you know. I mean, they don't need all the fantastic, you know, rearing and all of these different things. And the orchids are the ones you need the temperature right, you need the water not too much, not too little, and so on, you know. So they're very sensitive, yeah. And what happened is with the full-term children, parenting might be quite a bit overrated because we had low sensitivity, moderate sensitivity, and high sensitivity. And this is the academic performance on average which they had, which is a 0 line. Only if the parents were highly sensitive, you found also that they're academically at 13 years of age, they did better. Yeah? But here you can really see parenting is completely overrated. Is most of these kids, you can plant them and they do perfectly fine. So good enough parenting is enough. Yeah? But now you come to the very preterm children. And in the very preterm children, they are really these orchids. So you find when you've got really poor parenting, sensitivity, they do so much more poorly than kids who have got medium sensitive parenting to high sensitive parenting. In fact, the high sensitive parenting then did nearly as well academically than the controls. So it seems to be that they're much more vulnerable to poor parenting. And we did a meta-analysis where I don't know whether it's shown there, no. It's a meta-analysis which shows that actually overall, mothers of very preterm children are not less sensitive in their parenting, but just very preterm children need optimal parenting. That's the difference. They need more to do this. So now, what about peer relationship? So the interesting thing is my other area of research is where we publish a lot and put it on the map is about peer bullying and also about sibling bullying, which is the last taboo which exists, which is huge, is rife. And when you think about it, as kids grow up till 18 years, we have got this preoccupation with parenting. But by the time they're 18, they will have spent 3 or 4 or 5 times more time with peers than they will have spent with parents. And I find it absolutely amazing that we ignore completely the peer relationships. And we focus on parents like parents are the magic bullet who can change everything in your life. I mean, how many 13 or 14-year-olds come on and say, "Mum, I want to dress exactly like you"? Yeah? No, they say, I want to be like my friends. Yeah, I want to look cool, Mum, and so on. So they're much more oriented as they get older towards peers than they're oriented towards parents in a way. And one of the things, this is actually working together in the United States with the Great Smoky Mountain study. We published and analyzed the bullying behavior into adulthood, and we have done this in Britain as well. We find very clear differences. If you are bullied, you have more psychiatric problems, you have got more wealth problems, you've got issues with trust, building relationships, and so on. You've got poorer relationship with friends, you change jobs more frequently, and so on. So we wanted to see whether it's actually prematurity, or could it be how the world reacts to preterm kids that makes a difference to their outcome. So we have got here the German flag for the Bavarian study, the Epicure study, and we looked whether preterms, very or extremely preterms, are more frequently bullied than term children. And you can see they're more than double as often bullied by their peers, already in primary school. Okay? Then we looked whether they're bullied just one time or they're bullied at 2 time points. So that means we followed them up over 5 years, and during the time we recorded whether they had at several times they reported. Bullying means that they're bullied every week or several times a week, by other kids. And then we looked of their emotional problems in year 6, 7, which is at 11 to 13 years of age, whether bullying was related. In the Bavarian study, we found if they were bullied twice at times, they were much more likely. You can see this. I mean, this is one standard deviation difference of having emotional problems. But in the extremely preterms, we find even stronger effects. When they have been bullied, they're more likely to have emotional problems. We have just published a paper where we showed this in psychological medicine. We showed that they also, bullying explained about 3 times more likely to have psychotic symptoms. And it's related to bullying, not because they're born preterm. Yeah? So what happens is being born preterm increases the risk that these children are bullied more often, which leads to the emotional problems. In the Bavarian study, very preterm children, all the differences between very preterm and full term disappeared once we knew what the mechanism was, which was the peer relationship. Yeah? So, if we now do follow-up studies, this is again from this article, is we have to open this black box and we have to look how social factors make a difference to the outcome. And we will also be able to see how the social factors may make a difference, like looking at resilience or plasticity in their brain structure and their brain development. Do you find structural changes like cortical folding, thickness, or do you find fiber density? You find more axons being built, do faster transmission, and so on, which could be altered by social factors. But what I want to ask for is that the funders, and this has been our problem, and I've been like a terrier to try to persuade people, is they always give you funding for another big equipment, another neonatal scanner, another thing and things which you can put in. And then say, you do this, and then you look what the outcome is. And can you predict from early on to later? Yeah? But the point is, a lot happens during world. So if you do these follow-up studies, you have to fund to look at parent-child interaction, to look at peer relationships, look at the social influence that happens. Because the social influences make us who we are. Not that we just are, but who we are is how we go across the lifespan. So my conclusion now, coming to the end, is neonatally is pretty clear what you already have presented, that we need a much more family-centered neonatal unit. In 1986, it was one of my first articles on neonatal intensive care. I wrote on environmental care, and at the same time Heidi Als was writing in there and on this, and people thought this was very difficult to get in. You're crazy, like organizing walk rounds differently, reduce noise, and do lighting and doing all of these things. So we have come a long, long way since that time. We need gentler and safer treatment so that we basically avoid that there are more problems there. But preterms are more sensitive and are more exposed, like bullying, to adverse environments. And there we can do a big thing of trying to change it. And just coming back to this protective parenting, it's very clear that kids who become victims of bullying have been more protectively, I mean, it's a form, very protective parenting is another form of abuse, like abuse, because we found in the general studies, general population, that children who are abused, have trauma at home, emotional abuse, physical abuse, sexual abuse, or children who are highly overprotectively parenting are both at higher risk of getting also bullied at school. And those who get bullied at home are 3 times more likely to get bullied at school as well by siblings. So you have to work with siblings. One has to work with giving parenting where there are challenges. You see, I mean, if I just give the example of bullying, the worst thing that these kids say is, 40% of kids don't tell you or don't tell parents that they're bullied at school. More likely, if you're very overprotectively parenting and then you wondered why they do this lesson, I said, honestly, if I tell my parents, all hell breaks loose. They phone the headmaster, they phone the teacher, they phone the other parents. When my parents are through with me, everyone in the school knows that I've been bullied. So I rather don't tell, okay? So you have to be very aware that you need to deal with this in another way than just going all overboard with these things. So support optimal parenting. There should be much more focus on social integration and social skills, like, for example, preventing bullying, but also help very early on, like with sleepovers, having other kids around, and so on, to get more integration. And we need to do quite a lot more on parent and teacher training. We've worked with Sam Johnson together in Britain. And one of the things which we find very clearly, that teachers have got so little knowledge about preterms. Yeah? But the problem is, we asked parents, big survey of parents of preterms, it's equipoise. So 50% say, well, I would tell the teacher that my child was very preterm, and 50% say, I rather don't, because then they think he might be stupid. So there is a real question. The teachers say, 95% of teachers say, I rather know. So it's very difficult to do something if you don't know what might be the thing. So there's a very important area where we can do intervention, is the transition in school, working with parents and teachers, of how to manage that in the best way. And I keep on there. So that's, I didn't show you, I had at the beginning a picture of this. This is actually my grandnephew, born at 27 weeks. That's him at 3 years of age. He's now 7 and in school, so is doing all right. Thank you very much.
Mary, do you want to do a few questions? Okay. We do have a few moments if there are some questions out there. Dr. Volke, here we are. I'll let you take it over.
I think there was someone up there first in hey.
Am I going? Okay. I guess I'm wondering, as you're looking at MRI studies and thinking of connectivity in the brain and maybe how it's wired differently with the preterm birth, and then thinking about the fact that some of this is, we see a higher incidence of self-reported anxiety or depression or whatever, I'm interested to know, when it comes to the bullying part, if, not that I don't think there's bullying, but I also think there's a piece that for a lot of these children that I've seen in follow-up and even personally, they have trouble maybe with the more understanding social context, and so a lot of times can feel bullied or left out when maybe the situation was not that, but that's their interpretation and that's their reality. So I'm wondering how much that plays into, you know, the reports of bullying and that kind of thing when we see, okay, there's, you know, if it's daily going on and that kind of thing, if it's the child's perception, which is their reality, or if it's a true, you know, I think for children that have a visible disability, there's a lot of maybe grace and compassion that's given because you see the wheelchair, you see where for a lot of our preterm infants,
Okay.
that's not visible.
Let me break this down. So, of course, we can ask them themselves, which we did, but we also asked the parents. And we also asked the parents about how many friends they have, how often do they see them, do friends call them, do they bring them over, and so on. So objectively, they have got less friends, they're going less to other people's homes, and they get less invited. Okay, so that's the part of the objective. The second is their perception about relationship, and I think one of the problems is some social skills, is actually to join in, to do certain things. And as you already mentioned, physical disability is not much related to it. It's much more cognitive abilities. So if you have lower cognitive ability, you can't think yourself out of having different alternatives of doing that. It's not something you wear on your sleeve. You look the same and so on, but you're different, And that's what bullies do. I mean, a bully, I mean, if I would be a bully and I come in a class and you would be all in the class, what bullies do, I would try everyone. And the one who starts crying and runs away and doesn't have anyone coming up and said, leave him alone, and say it's an easy target, low risk, others join in, enhances my status, that's what happens. So it's very important for bullying. One of the things is to build a friendship group who can protect you, because protection in numbers. And the second thing is to learn skills. And preterms do have problems, have got more problems than that. But it's a great thing because we now have got something where you can target. You know, rather than having a black box, you could do something about this.
Thank you. Terrific lecture. Thank you for bringing this and all the work you've done. It's an amazing compilation. So first, thank you very much for that. Second is, I didn't hear anything, maybe because I was snoozing a little bit, because they took us out so late and fed us so much good food and wine. But
I had a lot of that too.
Well, you did much better than I did then. What was the sibling effect? I didn't hear anything about, did they have 5 siblings, first siblings? Was they firstborn? Was there any of that in the data that you were collecting to affect any of this?
I mean, whether you're firstborn or secondborn, I think the effects are very small.
Okay.
I mean, there are no effects really. But I can tell you what
They did have
effect...
siblings. They
Pardon?
did have siblings.
Well, some of them have got siblings. But this is now the interesting effect. I mean, there's a large Finnish study which shows this, because they could look at millions and millions of births. And what they have found, if you had a very preterm baby, you're less likely to have another child.
That's what I was thinking, yeah.
So what happens is, in Finland, they estimated that they lose per year about 7,000 or 6,000 births because of preterm birth.
Yeah, interesting.
And then you lose another 6,000 because the kids, the very preterm kids, are less likely to have children themselves. So it has a strong fertility effect.
Interesting, yeah. So, the other thing that just popped to my mind so much was these protective parents and the questions they get prior to discharge, you know, and the emphasis, at least a few years back when I was in the States, was, you know, can they be with kids? Can people come over? And it's so drilled into parents that they cannot have anyone around, and this and that lasts for 2 to 3 or 4 years through those essential early kind of play times. And I just have a wonder about that now.
I think the problem is not just with preterms. I mean, we definitely find with students, I mean, that mental health problems have dramatically increased in the last 10 or 11 years in students in general. So we had just had an open day, and I always ask them, you know, I mean, I'm coming back to this very day, is I always ask them and said, so, because a lot of parents go, you just focus on your exams, high school exams or A-levels, you know, you just focus on this, you know, I do your washing, I do your cooking and so on. And I said, would you ever send a child on a dinghy on an ocean and you have not taught them how to row, how to sail and so on? Because when they go to university, they fall at the first step because they can't cook, they don't know how to do a washing machine, they can't organize their day to do planning behavior of that you actually have to eat and you have to register for things, you have to find housing, and you have to study. And the parents have never prepared them for that. And then they say the universities don't do enough. And I say, well, I mean, they come completely unequipped. We have to start in primary school age of helping them. And I think if it even gets stronger, then this general tendency, I think that's happening with parenting, of not challenging, we get to the same problem as the allergy crisis. Because the point is, you know that when you grow up, the Augsburg study, if you grow up on a farm, you're 6 to 7 times less likely to ever develop an allergy in your lifetime. I mean, all this disinfection, washing and so on, because you never get challenged in your life to build up an immune system. And it's the same thing psychologically. If you're not challenged, you have no strategy of dealing with any of this. So I'm not saying that you should put them in the farm now, you know, this preterm children, you know, that you don't go away with the wrong thing. But I'm just saying that you have, in the individual case, to think when you could introduce, they're not vulnerable all their life. Yeah. One more question. Oh, there.
Thank you, Dr. Volker. That was a very slightly shocking result from your study. I was a little surprised. Especially
which was a shocking result?
That the parenting behavior, the more intense parenting, brought out a depressed social behavior in the child. For me, it was. I had thought that
no,
a more involved parenting or being intensely involved would have enabled.
No, sensitive parenting is very good. But sensitive parenting is individualized on the child, which actually means that which you call tough love, which is basically that you ask children to do certain things, but you're there completely to support them. And some people think that love is that you do everything for your child. But if you do, you know, if someone can't do their homework, you can do one thing and I say, well, I give you tips. This, you should restructure and then come back in half an hour and then we go through it again. You help them to learn how to do the homework. Or you can do it for yourself.
Right.
And the kid never learns it. And some parents think that love, ever seeing any distress in their child, or that it could be hard or something, they can't cope with it, they do it for them, but they leave them without any strategy for life.
But that is part of normal parenting. It's just like being a helicopter parent as opposed to being supportive, but in allowing your children to be independent. But what I wanted to ask you, 2 questions. One small thing, very small in your study. Was there any, did you separate out for the children who were breastfed entirely or not? And did you see a difference with that? And secondly, for your study, are there any new longitudinal studies going on, including the new things that we've learned about premature care, with all the things that we do, the family integrated care and the therapy and all the good things that we've learned in the past decades?
Okay.
So and results from those.
First question, breastfeeding. Yes, we did look at it. And when you put in all of the other variables, which you have got, breastfeeding doesn't come out as a predictor like for IQ and so on. I mean, the differences in the normal population is they are small, that they have got an effect. And it's often also taken away by social class, because if you're higher social class, you're more likely to breastfeed and so on. And when you take that factor into account, then the breastfeeding effect disappears for in the long term. So if you looked at the long term, we had it in each of the analyses. We always considered it. Yeah, it didn't have a effect size to write at home about. But of course, breast is best. You know, so no misunderstanding here. Yeah. The second question is about new, because the usual question is when you tell this to neonatologists, they say, but you know, everything has changed since then. You know, we have got surfactant, we have got different therapy, we are so much better. And it's absolutely true that survival has increased a lot. But for example, in Melbourne, the study by Lex Doyle, the VIC studies, had got 3 generations over 30 years, followed them up at 8 years of age, has found while survival has dramatically increased, quality of survival has not increased. It actually has gone slightly worse in the study. They had real problems publishing this. IQ got even lower at 8 years of age. So what happens is the Epicure study as well, Epicure 1 and 2, at 2.5 years, no difference. At 11 years, the paper is just being written, is no difference. There is no improvement in cognitive outcome. Survival has improved. So we have to make a difference. Survival is unequal to quality of survival. But what it means is we have got more kids, absolute numbers, more kids with problems in our community. Okay.
Thank you so much. Sorry we're out of time. So we're ready to move forward with our break. And we want to encourage you to do one last cruise through our posters and also visit our wonderful exhibitors and enjoy a little coffee break. And I need you to come back at 1:30. So at 30 minutes past 11. We'll see you then.
Okay. This next session is going to be an interactive session. This is your silo buster session. And there's going to be some I've got one of my own. Yeah. There's going to be some handouts coming around. I'm going to ask you to share, because part of this interactivity is we're going to do a little practice session. Then you're going to break into 5 groups. Okay? 5 groups. So it's you can move and that sort of thing. The therapy team is going to help you get organized we're going to do one in each corner and then some here in the middle. Okay? Don't be nervous. It's going to be fine. Okay? I can't read your faces. Come on in. Oh, are we okay? Is something happening? You want me to come over? Yeah. Okay. Wow, I feel like a celebrity. Okay. All right, there are no slides for this talk. This is all interactive, all right? I'm going to give a little introduction, and then we're going to just see how you can apply what you've learned so far into your own life. So hi, I'm Mary Coughlin, and and what I really want to kind of share with you before we begin the activity is a little information about a concept called the core measures. How many of you folks are familiar with a concept called the core measures? This is very good, okay? So, I know that there's different models out there for core measures. I'm happy to say mine's the original, just saying. And there are 5. There are 5 core measures. The core measures cover the healing environment, covers the family, it covers sleep, I'm forgetting, pain and stress, and then a last category that I call the activities of daily living, and it includes posture, positioning and posture. I'm moving away from the word positioning because positioning is doing to somebody, posture is supporting somebody. Eating experiences, I've shifted from feeding to eating because feeding is doing to, eating is autonomous. And skincare, bathing. So that's the other category. And when we first developed these core measures, I got to work with some pretty brilliant people. Dr. Sharon Gibbons, a PhD, NNP, out of Sick Kids in Toronto, Canada, and the late Dr. Stephen Hoth, a neonatologist out of Cincinnati Children's Hospital in the United States. All very passionate about developmental care, but very frustrated with the way developmental care is operationalized. That if you go into any NICU, basically anywhere on the planet, you ask somebody about developmental care in a NICU, everyone says they do it, everyone. But sometimes it's really hard to see it actually happening because everyone has a different definition of what it is. So what my colleagues and I decided to do was be very specific and almost prescriptive in what it would look like, what these practices would look like. But as we mentioned yesterday, these practices need to be operationalized within a larger context, right? It's about being with and having these encounters. Dr. Hoth introduced me to this concept called the Mobius Strip. Are you familiar with the Mobius Strip? So it's a ribbon that has the same surface on the inside and outside. It's the same thing. So it's a continuous loop. And he used that example to highlight that at the shared interface of care, okay, where, Melinda, can you come here for a second? Sorry, she's my example, all right? It's a pretty cool and I think profound concept. All right, when I'm providing care to Melinda, with this idea of a shared interface, the question is, where do I end and where does Melinda begin? Right? Because we're now a new entity. Can you buy into that? Yes? And this is what the caring exchange is. I'm going to make you stand there a little bit longer.
That's fine.
Because when we're with our patients, the care activities that are medically necessary, whatever, supportive and all that, aren't just things to check off on the list. That's not being with someone. That's not supporting them. That's not nurturing them. That's not honoring who they are and their presence and their validity as a fellow human being. Right? Okay, thank you so much. So as I talk about these core measures, it's really important that you think of them in that way. Because for me, the worst thing that could ever happen is for core measures in this concept of trauma-informed care to turn into a checklist. That would be heartbreaking. That just rips the soul out of the whole purpose of why we do this work. But the reality is that there's a lot of challenges and barriers in our environment to operationalize this philosophy and this approach to care. And a lot of them revolve around silos. So when I say silos, does it translate to the other cultures? It's just staying in my lane. I'm a nurse, this is what I do. You're the doctor, this is what you do. You're the therapist, and we just are all like attacking the baby to do our checklist. We have to bust that out, because who suffers? Patient, the family, And so we really need to shift how we approach the way we do our work. So on your handout, all right, there are 2 non-developmentally supportive examples here just to help you get into the groove of the activity that I want you to do, okay? And we'll do these together before we break into a group. And I stole these off of this company called Team Steps. They have these little scenarios that help you work with teams. So I'll give them credit, obviously. The last one's mine, though, okay? So let's just run through this. I want you to read the first one on page 1. I'll read it out loud. You read it to yourself. At approximately 2100, the NICU nurse who is caring for a 26-week-old infant pages the on-call resident or physician and tells him that she's concerned about the baby's color and that the baby is having more apneic, bradycardic, and desaturation episodes. The resident reluctantly goes to the bedside, examines the patient, and says he believes the infant is fine. 2 hours later, the nurse contacts the resident again and expresses her concern that the baby just doesn't look good. Does this sound familiar? Yeah. The resident reassures the nurse and says he thinks the baby's fine. But then 3 hours later, the nurse contacts him because she decided to get a blood gas. And the resident is upset that she got the blood gas, but the blood gas results are concerning. 721, 48, 63 with a deficit of -10. The resident examines the patient again, is unconcerned. The nurse then asks for the attending to be called, but the resident refuses, and it continues on. So just kind of an everyday example, this is outside of developmental care, right? I mean, I want you to just kind of get into the tactics of the situation at hand. What are the challenges in this scenario? Raise your hand. What's the challenge? Yes? The resident's not listening. I'm sorry? Anything else? The baby's not getting the care he or she needs. Yes, so there's a language, there's a communication challenge. As a nurse, we know what we mean when we say the baby doesn't look good. It's an intuition that we have about the baby. And it's causing a delay in the transfer of the accurate information for the patient. Do silos play a role in this scenario? Has anyone had this kind of an experience? And how do we overcome that? You can call the attending yourself. Pardon me? Better communication. Any other ideas? Call the supervisor. Yep. Yes, ma'am? Mm-hmm. Mm-hmm. Yep. So in the U.S., I'm not sure if this is in other countries, we use this SBAR format. It's situation, background, assessment, and I forget the R. Recommendation, thank you. And it really helps us with the communication challenge. So these are all strategies. Now, in the moment, it's not going to serve you because the patient is being waylaid, right? We're not taking appropriate action. But taking a step back, these are the actions that we can do. All right? Does this make sense? All right? And then a thought came into me and then it left me, so hopefully it'll come back. All right? So turn your paper over to the back. I'm going to give another little example. Yes, sir?
I just wonder with communication, the important thing is to have governance. I mean, because if these problems occur all the time,
Yes.
say, if you have got a conflict of communication, how do you solve it in general?
Mm-hmm.
Otherwise, you keep on going on
Yes.
having the same problem. So you need to have a governance. If you have got a thing, if you can't agree, you have to call someone.
You're absolutely right.
You need a procedure which is
Yep.
it.
Did you all hear him? So he's really, he's taking the bigger scope and saying, we really need to have a process around this, right? There needs to be governance about how we manage these kinds of situations. And oftentimes there may be governance around this, but that information may not be filtered down to the frontline clinician. And we're going to integrate that into the last scenario, what I'm calling your final exam. But thank you so very much. You're absolutely right. So in my second scenario, you're in a level 2 NICU. The average census is 5 or 6 patients. There are only 3 ventilators available and 1 respiratory therapist. And I know the respiratory therapist role is not ubiquitous across all countries, but for this example, this is the person that's responsible for the ventilator and the airway, if you don't have a respiratory therapist in your environment. So that's his job or her job. The ventilator that there currently is available is being used on one of the patients. A second ventilator is on transport, and the third ventilator needs to be cleaned. The respiratory therapist has some other responsibilities that they're doing, then decides to go take a lunch break, and then he comes back because he gets called for an emergency situation, and the ventilator is needed. What happened? The ventilator's not cleaned, okay? So what are the challenges in this scenario? I kind of suggested it, but what are the challenges? What do you think? Priorities? But something else. Lack of resources, yep. And again, coming back to Dr. Wolke, there's a process around this, right? So, I kind of said at the beginning, this is his job. The respiratory therapist is supposed to take care of this stuff. Can't anybody else take care of this stuff? Right? So couldn't that cleaning of the equipment be delegated to somebody else, not clinically, a clinically critical individual? Because again, we might say, well, he shouldn't have taken his lunch break until he cleaned the ventilator. That may be true, but doesn't he deserve a lunch break as well? Now, I don't know this person, okay? These are sterile human beings here. I don't know if he's a lazy slug. I don't have any of that information. But in general, right, we all have a responsibility to make sure that the resources are available when we need the resources. And actually, in our world, we need them before we need them, right? We need to have things ready for that critical event. But leaving it up to one individual, that's her job. That's his job. Who suffers? The patient, right? So that's the idea around this. So for me, the challenge is, a lack of resources for sure, a lack of process around how this is going to be addressed. In the scenario, it was very succinct, that this is it, and he fell down on the job, is the impression that I was left with when I was, looking for different scenarios. But did he really fall down on the job? What's the larger scope? None of these are simple, direct things. And so on your final exam, I'm going to ask you to really dig deep and think about all the different facets. Yes, sir? Yeah, exactly, right?
So you actually would need, even if it's not someone who's just a resident, could do it in this situation to have an understudy if there's a, is a problem. It's resilience of the...
Yeah, the system and the, yeah. So Dr. Wilkie was talking about, in the theater, you have an understudy, who kind of in case something bad happens to the lead guy, they step in. That's what we all need to be for each other. When we're looking at introducing new practice strategies, it's not just the nurse's responsibility to make sure that all this stuff happens. It's the team's responsibility to work together for the common good of the patient. But sometimes we stay in our lane and we don't help each other. And when we do that, again, we're certainly messing it up for ourselves, but the patient suffers. I'm sorry, we can't do that. We don't have enough staff. I'm sorry, we can't help you, kangaroo, because I don't have enough nurses. Do you have anybody else on the floor? We just need a human with a beating heart and 2 hands to facilitate. I think you've got a plenty of them around, right? It's thinking outside of our lane that's really going to help us operationalize this. When I come to conferences, which I absolutely love to do, you learn so much exciting new information, and you're full of energy to go back home and figure out how you can implement it. But oftentimes, you ram into the same old wall, right? The same barriers. Oh, I forgot, I work here. We never change anything. This is how we always do it. And your enthusiasm just, right? But in this situation right here, in this setting right now, I really want to stimulate your creativity. I want you to think outside the box. I want you to have some courage to really take that action. You have to take it respectfully, of course. You can't just go in there all, boss everyone around. We have an expression, you catch more flies with honey. I'm sure you all have a similar expression. It's true. But you can't be phony, right? It's about authenticity. A lot of the things that we talked about yesterday, it's about being compassionate for ourselves and our colleagues. Most of our colleagues are multitasking. They're overwhelmed by the environment. So how can we, being reinvigorated by this conference and all the networking that we're doing, take that invitation to think outside of the box and say, hey, I have an idea. Instead of it always being the nurse, maybe we could have the parents be the second person for a painful procedure, right? Or have the physician. It doesn't always have to be the nurse or always have to be the therapist. It needs to be collaborative. When we look at the principles and the values of a trauma-informed approach to care, safety is number one. But we can do everything safely. We're experts. Everyone in this room and all of your colleagues back home are experts. So safety is how we operate. But safety also oftentimes is the mask that we put up because of our fear of change, our fear of doing something new that makes me feel like a novice again, those kinds of things. So we need to be mindful of that and say, okay, I understand this makes you nervous. Can we come together and agree at some place to start? But you don't stay there for the next 30 years, right? You push the needle slowly but surely. All right? So I'm going to have you break into groups. Do you get it? Do you get the idea of what it is that I'm wanting you to do? I'm going to give you a situation. It's a after the fact situation. You're going to read a little story about this baby who was formerly premature and now she's going into nursing. And all of the challenges that she's faced, through her life. And then you guys are going to create an action plan, a care plan. We don't know how she was cared for in the NICU, but I'm going to invite you to write a care plan. On the back of page 4, there's some columns. Just write some bullets, some bullet ideas about what we could do as a team that might address some of the morbidities that are identified in the scenario. And these morbidities are not the majors, they're the minors, all right? The minors that are very major in the lives of these people. Okay? All right, so hot-footed. Let's all break into groups. All right? I'll break the room up. I'll help you out a little bit, okay? Everybody up there, you stay right there, okay? We're going to just move you guys here. Right there. I see you right with the yellow. Yes. Go on over there, okay? And then you guys over here with the coat, move on over there, okay? You guys here, come on down to Thomas. All right, you guys come right down with Thomas. And we've got a gaggle over here. Let's just go. Come on, get up out of your seats. Move up. Move. Find a group. It's okay. There's no number restriction. Just find a group. Move. Up. If you're confused, just follow somebody else who's moving. follow Stephanie. I just want them to break into groups. And then we'll have one group here in the middle. Yeah. So I need 5 groups. Are you going to help me do it?
If you want me to, yeah.
Yeah, just...
It's on. So it looks like they're doing it.
Are we all good? Assign somebody the scribe. Somebody has to be the scribe, or you can all scribe at the same time.
Are we doing 5? How many?
That sounds good. You got them? Yep. So is that a group right up there? All right, you guys with the jean jacket on right there, you guys with the shawl, you're a group. So you come be that group. Just come and sit together, look at each other, and chat. Read the scenario and start chatting. There you go.
They're pretty big groups.
I know.
Interesting.
But it's okay. So I actually copied this out of the textbook. It's really long. Because your story was really good, but I was it was all disconnected, so I thought, I don't know how to connect it, because you guys talked a lot through it, and I was like, it's not my own. So the story actually begins on the very bottom of page 3. So everyone read from the bottom of page 3 where it says Tracy, Shannon, and Erin. Oh, you're so kind. Water would be fantastic. Yes, thank you. The chapter on trauma-informed care. It was really hard to pull something out, but it's a pretty involved story, but it talks about her long-term morbidity and stuff, and then I just want them to make a plan.
When you said book, I thought you meant the ebook.
Oh, yeah. I'm not sure. Please share the case, because I don't have enough for everybody, okay? So just look on, read on, or have somebody read the story out loud. I apologize. You got 2 minutes. And it's okay if you don't finish everything. It's just to really spark some, critical thinking. 2 minutes. 2 minutos. And as you're winding down, I want you to summarize what are your 3 key insights. 3 key insights. And a spokesperson from each group will share. Do we still have the microphone? Oh, awesome. All right, I'm going to ask for a representative from each group. I know, you're so engrossed, but this is awesome. You keep that energy going, and I want each group to share 3 insights. 3 insights from your discussion. Insights are, revelations from the discussion. They don't necessarily have to be about Katie, all right? You've all begun a very interesting discussion about what you could do better based on the story that you've heard. And I can hear and feel your energy and your enthusiasm, and really invite you all to pay attention to me. Look at me. Stop talking. Per favor. Obrigada. So we're going to ask each group, okay? I want each group, you all, I hope you engaged in some good discussion. It felt good. I don't need the answers today. Okay? I don't need the answers to this. It's not a finished product. Energy, people, energy. No. Okay, everybody, look at me. Look at me. Nice deep breath in through your nose. And out all the way. And then bring those arms up. Give me some jazz hands. Woo. Let all that energy out. Thank you. Now no more talking except for me. Every group, I want you to raise your hand when you're ready and share 3 insights, 3 discoveries, 3 ideas, just 3 of one of those, okay? Because we do have to be mindful of the time. But in your discussion, what did you learn? What 3 things did you discover as a group? You can share anything you want with me. Raise your hand when you're ready.
Who's the speaker for this group here? Okay.
Microphone.
I would say that we came up with ideal care very quickly. Probably in 5 minutes, we had the most ideal setting for this infant possible and family.
Yep. So, but in the discussion, right? I mean, were there any insights or discoveries from the discussion? And it's okay.
Yeah. Q6, hands-on.
Yep. So you identified some of the traditional practices, and the group shared how easy it was, out of the context of reality, to just draft the perfect dream care plan. But how to operationalize that is a whole other kettle of fish, right? That's where we get into the silo busting, and how do we overcome those challenges. In your discussion, did any of that come up when you said Q6, hands-on, that sort of thing? Was there any discussion about how do we navigate that? How do we work around that? How do we shift it?
Everyone was really on board, Mary. We had a very cohesive group. I would also say that the support for the dad came through in terms of the dad and grandparents providing skin-to-skin holding, paternal leave for the father, so that he could be away from work, and the bereavement support that he would need. I think we dialed into that quickly.
Beautiful.
Compared to maybe what happens in reality, because, you're distracted.
But now, do you feel like emboldened? Do you feel like you've cultivated a little bit of courage maybe in articulating what your plan is? Does it feel achievable? Exactly, one small step at a time. Thank you very much. You guys rock.
Great. It was great. And I felt like what you said about the 5-step greeting.
It was because of the anxiety and depression she is experiencing. We tried to work with a 5-step dialogue with the baby, and we start by preparing the things we need to do for the care, and then we ask permission to the baby if it's okay. So we start by opening the isolate and talking to the baby, and then when we see reacts, then we touch it, and then we do the care, and we keep in touch all the time with the baby. And then after the care, we help him get to sleep by staying at the side, and then when we see he's quite drowsy, we leave him for sleep. So it kind of delimits the time for care. So between he can sleep, and it helps not going into toxic stress when you don't know when something is going to happen.
Yeah. Beautiful, beautiful. Thank you so very much. I was going to say, did anyone else do that? That's awesome. All right, big clap, big clap. Thank you. Who are our next volunteers to share their discussion? Okay, over here. You're on deck.
Okay. I'm a little bit nervous, I confess.
It's okay.
We discussed this case, and we. Okay.
Look at her.
Look at me. Peer pressure. Okay. As I was saying.
Yes.
We opted for another path. We discussed the life she has now as 16-year-old, and we focused on two key insights because we didn't have time to discuss.
It's okay.
Okay. We talked about family, and we talked that she has lots of family support in the. That's a positive thing. Yeah. From her father, from the nurses, therapists, the professors. She has lots of support, and that's a positive thing. We talked as well about environment, and in the case there is nothing about if she has friends, if she does activities or sports, and I think we thought that that was important to know because of stress as well.
Yeah.
Peer pressure.
Yep.
That's would be a negative influence to be.
I'm going to speak with a Portuguese accent.
No, don't.
Just some of the possibilities of the nurses and the father living vicariously through the loss of the mother and having some pressure imposed on her to become a nurse, and just maybe exploring that in light of her sensory motor processing depression,
Challenges.
mental health challenges that she's having. That would be something to focus on, some strategies for the future. Beautiful job with that. Okay. Oh, sorry. Did you finish up?
Passing it down.
It's only to sum up and add up some other things.
Yes.
So we believe that she, of course, had a lot of support from her family, her nurses, therapists, that she said that it was really a grateful point. But we also discussed that the support of the family, because firstly she exposed her interest in nursing, and the family started supporting her a lot, and we concluded that she could feel a little bit of pressure. So that's why we wrote down that the family, they can support her, but with realistic expectations, like without trying to, you're going to be a nurse, you're going to be a great nurse, you're going to be a nurse, da, 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 da. So, we think that it could release a little bit of the stress that she could feel. That would also lead to the pain and all the depression that she has.
Yep, excellent, excellent. Thank you very, very much. Very good. And now we're going to do this group here in the middle. And then I've got two. Okay.
Our group decided to think about this little girl at 23 weeks, not at her current age. And we started with the first category of pain and stress, and we took off in all kinds of directions from there. So trying to get things written down and move through it got interrupted, my intention, by some really interesting and good stories. And I think that's my reflection, if I can share with the group. People had a lot to contribute from their lives in this story. And instead of writing down all the things that we sort of allowed time for that. And I think that was really valuable and appreciated. And besides, like the first team, I think it also shifted to father and the family quite a bit in terms of pain, and that the whole family's in pain. And how do we address and support, ideally in some ways, and in some ways, even in that ideal, people came up with barriers within their own hospital systems that might make that difficult. And that was their story, and maybe some of their experience and frustrations in their own. So coming from so many different places and experiences, even if we don't have much on our paper, I think we shared quite a bit, and it was a nice experience, at least from my point of view. So
I think one of the gifts of doing something like this is that it takes you outside of your everyday mindset. So in the NICU, at least in my experiences, I don't often think about these people post-discharge. My goal is to get them to discharge, and then, obviously I wish them well, but there's a gap in my understanding about what happens on that other side. So that's why I like this scenario, because I think it shows that, and you touched upon it in the way you shared your group discussion. It reconnects us to that human being and not the diagnosis, right? It's this, kind of bringing it back to, our shared humanity.
Well, one of our members in our group had a preemie, and so that was some of the story that was shared, and it brought us to a different understanding than just this story.
Yeah.
But does anybody else want to add more?
Yes. Yes.
In our unit, we have a 24 weeks baby. He was born in a storage. He lost his baby twin, his brother twin. He came to our unit with his dad. His mother stays at the hospital 2 weeks, so he stayed with us alone. His dad comes to the unit, asks for the baby, and leaves. After 2 weeks, 3 weeks, Mama comes to unit, but she cannot connect you with her baby. She is afraid to lose him again. I am very preoccupied with this baby and his future and with this family. It's hard to take care of him. I don't know how to help this family. It's difficult for me to. They don't stay very much time in the unit. Mother and father come to unit and ask for their baby and leave again. They do not have
attachment. Yeah.
No abertura. They don't give open to our words and our support. They are suffer, too much suffer.
Yeah.
It is difficult for me to think how this baby is going to grow up in the future.
You got it? Yeah. Marilyn wants to.
I'll go after Marilyn too.
I think
Mary.
that this is a challenge worldwide. It may take a different form. It could be a maternal death. It could be a maternal illness. It could be being transported very far away from where the mama is. And one of the things that I try to focus on from the very beginning, and I suspect you are trying to focus on as well, is please look at your baby, not at the wires, not at the monitors. I find that, at least in my country, when parents come to the unit, the first thing that people do when they greet them is to explain the equipment. And I would suggest that maybe we have that backwards. That if we can focus from the very beginning on your beautiful baby, and I always find some way of framing that, and even noticing the smallest connections. So when that mother comes in, for example, oh my gosh, do you see how he just looked at you? It's not an instantaneous cure, but I think the more that we can get parents, no matter what the situation is, and some parents just get this intuitively and instinctively, and others need to be mentored and facilitated along the way.
The only other thing I would ask is what type of mental health support or resources are available. Psychologist? Yeah. I would definitely make a referral to the psychologist.
And
Not supportive.
And I would say, too, in regards to that, as a parent with a really small baby that looks, and everybody will understand what I say in here, at the one conference they showed a video of a mom who described her baby in a box, right? And she didn't know how to love this baby. It's not a normal baby. That's not a normal feeling. So there's a recognition of sometimes, and with this mom it's probably more, which is why the mental health is so important, the aspect of it. She lost one, and so she's probably deathly afraid to attach and lose the other. Yeah. But in addition to that, it is horrifying as a parent to look at this little alien baby in a box and not know how to love it. And sometimes our job as nurses is to help that family love the alien baby in a box and find things that are normal, and that will take time. And sometimes we have scent cloths, and sometimes the first step to trying to kind of bridge that gap is saying, the baby can smell you, the baby can hear you. Those types of things, the little steps. But it's very scary for them. And just so you know, you're not failing the family. It weighs heavy on our heart, but you're doing everything that you can in an absolutely traumatic situation for them. And know that everybody in this room understands that. Yeah. You're not alone.
Yeah.
Yeah. If I just say, because the psychologist came into this, I mean, the first thing I would say is a very important thing. This mother is showing a very normal reaction. I mean, if you get attached to someone and you lose them, it's very, very hard. And you now see the other person, you get sort of, you have to reflect. I mean, the first on it, is it the staff who wants her to attach, or is it her? Maybe the first thing, nothing is lost if she doesn't do it, because we always think, I mean, Kendall and Kendrick, that's out of the window. You don't just bond in the moment magically and everything is fine for life. It doesn't happen like that. We know this now. So the important thing is it doesn't matter for 2 or 3 weeks that she can't be that close, but maybe we focus on the mother and actually talk with her what it is like, because everyone is making her to be even worse, because now you're not a good mother. I mean, first you lost a baby, and then you're not a good mother to this second baby, yeah? So we might have to focus first on the mother to talk with her, and then slowly do exactly what you said, like, for example, giving positive reinforcement. I mean, I would be anxious, wouldn't you? I mean, so we shouldn't make it, it's a normal reaction, and say, this is perfectly normal, let's talk about it, what this is now for you, and then find her solutions of how she can start bonding with it, because it's such a fear. So I think it might be sometimes, it's like with this girl we talked about to become a nurse, maybe there's so much pressure about it that she has to be the perfect mother now to the second child. Just give a little bit of time and talk to her.
Do you want this group?
Let's do this group in the corner here, and then we'll finish up with you guys over here. Go ahead.
Okay. Our group also discussed about Katie's and her family experience during the NICU stay. So the major considerations that we discuss here was okay. I need to practice for later on. Okay. We think that the basis is to establish a heart-to-heart relation between the professional and the parents and grandparents. Because if they are if they feel supported, we can facilitate the connection between them and the baby. That's the main core.
Most important.
Okay, the most important.
Mhm.
The relation we establish. And we talked about the family collaborative care, of course, has the base of all this, and we also discussed that we still need to move from a caring. What can I say? Yes, to just care to não é caring. O que quer dizer? De curar, de cuidar, de curar para cuidar. I'm so sorry.
It's okay.
Because we think in Portuguese.
Yes,
so
oh, I
it's
completely understand. I completely understand and respect.
Okay. We think that we need to move from it's missing a preventive culture
Yes.
in the NICU for all of us, all the professionals. But we feel alone. We feel that just a few nurses think like this.
Yes, yes.
And it's hard.
Yes.
And we are discussing here that in their NICU, the nurses think in the same way, which is wonderful. We can connect to parents more easier, yeah. But they have the difficult to embrace the doctors and the other professionals. What we were trying, I'm trying to say, it's I believe that first one thing we can do is to do the other way round. Instead of being us professionals, to include the professionals, we need to include parents, and parents will
pull in the professionals.
The other professionals that cannot think like us. I
Yes.
don't know if I...
No, I understand what you mean. They'll identify who they need, what other services they need, what other professionals.
Because they truly need to establish a relation, a connection to... If she knows I like her and I like her son, and I'm connected with do you understand?
Yes, I do. Yeah.
She will feel empowered.
Exactly, that's the word. Yeah, empowered.
She will feel empowered, and she will feel. Eu quero fazer que eles querem nível de educação, eles vão querer tanto educar. Estás a ver? They will their needs, educative needs. We don't. Can I say?
Oh, no, you're fine. I think what you're saying, you tell me if I'm wrong, but I think what you're saying is by connecting with the family and empowering them, we validate them as the parent, and they feel they have a real role then, and then they partner with the professionals.
And then with that, I believe, with that, the other professionals were not connected with this kind of
thinking.
Do you understand? They will change. Yes.
Yes, they will change.
See,
yes.
And we'll see. So
yes.
I believe it's this. We have to connect with parents first. Yes. And when the baby, being a facilitator, and in this case, particular case, and have changing to to a more healing environment, healing care, and having a more preventive culture.
Exactly.
In the NICU.
Yep.
They are the key points, because she had sensory processing deficits and a noise, touch.
Yep.
I don't know if that parent and grandparents had if it was available, emotional
Exactly, if they had the
available
understanding, yeah.
and no, emotional available to that child, to that,
okay. Yeah.
to Katie.
Yep.
It's
yeah.
Oh, I'm so sorry.
No, you did a fine job. You did a fine job. Absolutely. Very good. And our last group, before our next presenter. Yes, Teresa? Do you need a microphone? Yes, it is. Take the microphone. There you go. Yes?
Okay. Everybody talks a little bit about this case, and we want to talk about the environment because
Let her
she's
finish.
very sensitive to the environment. So we thought that what we should do to other babies, because this is a grown-up girl, so we cannot do anything about the environment. And sometimes it costs a little bit, but it's not too expensive to have equipment for measure light and sound.
Mm-hmm.
And to do especially audits, because sometimes when they know there's equipment, they have to be, the personnel are more careful, but they forgot a lot of times to do what they know they have to do.
Yeah.
So measure the light and sound, it's a very necessary thing for all the babies, and we see the result in that girl. Redesigned some units because the telephones are very close to the babies, or the fridge are very close to the babies, like ours.
Yep.
And it's a huge noise making every 24 hours. And comfort measures, and especially kangaroo, because it's very good for everybody who does and for everything.
Excellent. Thank you so very much. You've all come up with really great strategies, really great ideas, and the next step now is to really start brainstorming about how do you implement, how are you going to test these ideas in your setting, engaging with the folks that are already there, and make these changes happen. Because prevention is really the idea. Trauma-informed care has a different connotation in the neonatal world versus mental health. Mental health, it's already passed, right? The trauma has happened, and the trauma-informed approach is understanding their history and then engaging based on that history. But for neonatology, it does have a preventative approach. We recognize that the experience that they're about to undergo is traumatic. And so that knowledge invites us then to change, to prevent a lot of the bad things that we know are going to happen in that setting. So thank you very much. I hope it stimulated some critical thought, critical thinking in your heads and stuff. And we can continue the discussion later on about how we're going to really operationalize these ideas. Sound good? Woohoo! Okay. What's the problem? So does our next speaker know that?
No, but that's a suggestion.
Okay. Paula, if you'd like to speak in Portuguese, we could have the English-speaking people wear headphones or whatever you prefer. You brought it in English? If you're cool with that, that would be fine. Okay. So I'm very, very honored to introduce our next speaker. We're now... We're beginning our special section called the Spotlight Series. I have to put my glasses on. Go ahead and find your seats. So she will speak in English. She will speak in English. Okay. Oops, I hit the clicker here. No, she's going to speak in English. I asked her. I gave her the option. Yes. So I'm very, very honored to invite Paula Guerra to the podium. to present her story. Paula is the mother of a former premature person, and she is also the president and founder of the Portuguese Association for Premature Parents in Portugal. You're most welcome. Give her a big round.
With this?
Yes, you can. Oh, there you go.
Okay.
Sorry. Okay?
What? Okay. So thank you so much for the invitation. I'm very, very happy to be here with you today. I will try to do my best in English, speaking in English, and I apologize in advance for the mistakes that I could make during this presentation in English, okay? So sorry in advance for that. So I'm very happy because I was thought before when Mary invited me several months ago, which topic should I bring to this Congress? And because the Congress is about trauma, and parents also have trauma during this traumatic situation, being parents of preemies. So I bring the communication with parents also. And as you mentioned before, I listened several times during these last minutes that communication is a topic, a huge topic that we all of us should improve, not only in health areas, but also in my organization. I work in a bank. I'm from the IT department. I'm a director in the BPI bank, and I give training in communication in our bank also. So this is very important topic. So I will talk a little bit who I am and why I founded the association, then a little bit, just a few minutes about our organization, and the main, the majority of time I will spend in communication, okay? So, who am I? I'm a mother of a girl. She's now 18 years old. She born with 26 weeks of pregnancy. She stayed 3 months in the NICU, 2 months and a half in the intensive care. She had a lot of problems during the hospitalization. She had a lot of surgeries, operations, lungs operation, heart operation also. She had 3 pneumothorax in the first 10 days of existence after birth. And it was a traumatic situation for all the family and also for friends. And I had an experience in the first 2 weeks. I drove all the days to the NICU, and after 1 week of her birth, my legs, because she had the first problems, huge problems, and my legs and my arms became shaking all the time, and for twice I couldn't take the car to the unit, so I call some friends and some colleagues, because the unit is quite near of my bank, and I call them to help me to take the car because I couldn't be able to get the NICU. And this gives me the information that I shouldn't take care of myself before take care of my child also. So because of that, I started to study a lot of the impact of having a premature baby for parents, and also what should I know and learn to take care of my child after. Okay, here is the surgery that she did in the lungs. So about XXS, we are a group of parents that had the experience of being
parents of preemies, and we founded the association 7 years after the Beatrice born. I was helping the parents during that 7 years, but I only found it 7 years after her birth. And our purpose is raise awareness of prematurity and ensure specialized care and work with professionals. Like Mary was saying, that we shouldn't work in silos, and even parents shouldn't be in a silos. Silos, that the accents? Okay, in silos. Parents should be working with professionals, working with other stakeholders also, because the diversity of experiences and the different points of view are very, very important for improving our work and the quality of our services also. So this is very, very, very important. And support another purpose of our association is support families and parents of premature babies. Contribute to improve parental skills is very important. That has train not only you as professionals that could train parents, but also other parents that could have the experience and other skills, because we parents we have our knowledge about our work and our professional areas, academical areas, so we could bring also good things to train and good things to teach to the others. Contribute to improve parental skills, as I said, promote partnership between parents and health professionals, and dialogue with other stakeholders, and promote the implementation of infant and family-centered developmental care. We also are working, and this is work that sometimes don't appear, nobody knows that we are doing that, but we are also working with the government to change the law, to have more benefits for parents. We changed the law, and this year is approved in the budget of the government for this year, the improve of maternal leave. I don't know if every one of you knows. We were, thank you. We were trying to change the law for 8 years and a half, and last year it was approved. And with the budget of this year that is approved now, will happen the extent of maternity leave, not only for preemies, because we don't ask only for preemies, but for all the babies that born with some disease, and the mother and the parents and the baby is not discharged, doesn't go home at the same time of their mother. Okay, so sorry, I think. Okay, and now I bring this sentence, this quote from an actress and dancer, because she explains very well what is the impact of communication in all of human being. So people forget, she said that people forget what we said, people forget what we did, but people never forget what we made them feel. So this is I think it's the most important thing that we should know when we are dealing with others. We are communicating with others. We need to know how we make them feel and put in the other shoes to know if it will be with me, if someone speaks with me like this or like that, what would I feel? And we should be aware of this, okay? If you don't understand something, please raise your, yeah, okay. So, a real story of mine. Because of that experience that I mentioned before, that I couldn't be able to get to the unit by car, driving the car, I realized why this happens. It's because of the stress, because I didn't know at that moment when I arrived at the unit how it will be my child, if she's okay or no. The first thing that parents do when they when they arrive to the unit is to look at the face of the nurse. I don't know if you realize this. It's the first thing that we do every time is look the doctor or the nurse that is near our baby to see how is the face, to see the body language of the nurse. And we understand with the body language of the nurse, we be aware that something is going bad or something is good, if it's stable or not stable, is the expression of the body language of the nurses. So this is very important. And also the communication. So what I did at that period was I put everybody, even my family, people from my family and people from my colleagues, I put everybody in 3 different boxes. The red box, in my mind, I have 3 boxes, okay? The red box, the yellow box, and the green box. The red box is the people, and also from my family, that I don't want to talk with, because they put me on stress. They communicate me with, and they ask me questions that higher my stress status. Yeah. So I never, of course, I say hello, I give a kiss, but I never start a conversation about the child, or if someone asks me something, I told them, okay, I'm not feel very well or very good to answer you, please. I need some silence and I need time for me, and I never talk with them, okay? And even professionals and nurses and everyone, I put these kind of persons that need to improve a lot communication skills, I put them in a red box. And the others, the good ones that make me feel better, and help me and give me information, and I put in the green box. And the others that are not so bad or so good, I put in the yellow one. And the realistic, sometimes I put the realistic because some of us, my husband is a pessimist. He's so pessimist. He thought that everything goes wrong, and it was very bad. So sometimes I don't even share with him, because he was working all the time. Every day he came to the hospital, but most of the time he was working. And in the end of the day, I share some information, but not the bad information, because I knew that he goes down quickly. So I protect also him. So we need to be strong and help each other, and sometimes we need to change our way to because I am a person that shares everything, but at that moment I realized that I couldn't share with him because he needs help also, and I protect him from this. So, and the realistic doctors and nurses that are in the yellow box, I only talk with them when I was very, very strong. The days that I'm strong, I think I could I could can I say it? I could ultrapassar, overcome every challenge. I talk with the realistic one, because I knew that they give me, they will tell me the truth, and the truth is very important, of course. But I know that, but I only talk with them when in the days that I was very, very strong, and I could listen everything, you know. So this is very important for you to know that parents do. Some of us do this, and I help parents also when they are talking with me during our sessions in our association, and I tell them, if you want to protect yourself, maybe you could do this or something like because each one of us needs to find their way to do it and to protect themselves. So this is important for them. So why communication is very important is because help us to avoid misunderstandings, establish relationships. If we could empathize with the others, if we understand and put in the other shoes, we communicate better, and we establish also good relationships. And good relationships improve negotiation, increase the collaborative with the others, even in peers, between professionals, between doctors, and between doctors and nurses, peers also. And increase productivity. All of us be more efficient if we share, if we communicate each other, if we don't stay in silos, as Mary mentioned before. So we will have better results, and with impact on people's satisfaction, motivation, and happiness. And this is a problem, I repeat again, is not only a problem in the health system, is a problem in every company. We should improve communication. And what I bring here is one of the most tests of people profile, people preferences, are MBTI. I don't know if you know. MBTI is Myers-Briggs Type Indicator, is one of the tests that the talent headhunter companies in the recruitment do for identify how we are how are our natural preferences, even in communication, okay? I bring this to share with you because you could study more if you want to, or if you want to call me, I will be very pleased to help you with this. But all of us are different. The way we learn is different also. Some people learn listening or reading. Some people learn better with experiencing the things, you know. I have two doctors, and they learn differently. One of the one that born premature, she needs to experience, she needs to understand why I'm learning this. This will be applied where, in what? If she didn't understand that, she doesn't understand, she doesn't like, and she doesn't learn so well. So we have different kind of people. I will read this because it's a lot of information here. But we have people that are energized by people, that enjoy a variety of tasks, that a quick pace. Everything is quick. I'm like this. I'm this kind of people. That this kind of person. I like to have a lot of tasks to do, and I'm a multitasking person. It's difficult sometimes, but I like to do it. Maybe I don't do everyone so well as the one that is in the right side. That people that are often like working alone or in small teams prefer more deliberate paces, focus on one task at a time. And when we are dealing with parents and the professional, you should know and should understand. And if you observe and listen, you will know which kind of person is in front of you, okay? And another kind of people is the realistic people that focus on facts and details. They apply common sense and the past experience. They decide most of the time with all that information and the past experience also to find practical solutions to solve problems. And the opposite is people that prefer to focus on possibilities, on the big picture, easily see patterns also, values innovation, and seek creative solutions to problems. I'm this kind of people. In the first I'm an extrovert person, and in the second I'm in the right side of this board. And another kind of people is also the ones that tend to make decisions using logical analysis, objectively with pros and cons, okay? I'm not like that. I'm the opposite. Tend to be sensitive and cooperative and decide based on their own personal experience and values. And also, I also, most of the time, I tend to make decisions also understand what my actions will affect the others. But one thing that is very important in all of this is that nobody is only one or only, all of us have everything of this, okay? But tend to be more, our rates, our individual rates is differently. I'm like 80%, almost 80% in the first, in the first one, but not so much as in the second line. Okay, it's more balanced between one and the other. And in the last two points there, in the left side, people tend to be organized and prepared, like to make and stick the plans, and comfortable following most rules. And the other one is people that prefer to keep their options open, like to be able to act spontaneously, and like to flexible and with making plans. I'm also in this that prefer their options open, and my husband is the opposite. He likes to plan everything. When we go back on vacation, he knows in the first day we will be there, and then we go lunch there, and it's a nightmare for me, you know. But for him, I am a nightmare for him. So we need to adapt, and this is the good thing, is to know this and adapt and also sometimes don't force, and sometimes I do as he likes, and sometimes he does as I like it. Okay, this is the what we need to do as human beings when we want to collaborate and to have good results in everything. Everyone understands this? Yeah, it's useful for you to know. It's good for you. Most of you knows that, but you could do an online test and identify your preferences, okay? And this is innate preferences, because today, because I work in a bank and I need to make too many decisions. I need to deal and to lead, to help my teams. So of course I sometimes, because of my work experiences, I become less I adapt myself, and sometimes I decide more. I stick more my plans and my stricts, you know, but it's not my innate preferences. Okay, if you do the test, you should do it and not as you are now, but what you prefer, what your natural preferences, because you can't do it you can't do it. The tests bring out your experiences, professional experience to the answers. Okay. Okay. So I put here the letter. The letter is He is an extrovert person. I is an introvert person. A sensitive, an intuition. The N is intuition. The thinkers is the T. The feelings, the feelers, and the judging that are very organized, and the perceiving people. Okay, I'm a E. My is a he. My profile is a E. N. F. P is mine, is on Myers-Briggs type indicator. The Myers-Briggs type indicator brings 16 different types of people to understand, and they also, with this, helped us to identify others, and also to adapt, to say, they have a table that have some information about what stress, which kind of things stress the others. So it's very important in communication also that we be aware of this. And we have another kind of tests that could identify, like process communication model is another one. I'm a coach. I'm certificated in coaching. So we learn this, and we have a lot of different kinds of tests and sometimes questions that could help us to identify what kind of people. And now I want to tell you also that we, because of this, we tried in our association to create some tools that could goes to the preferences of each parent. So this is very important when we are deciding, and also when you are deciding some methodology and some practices in your unit. It's very, very important that you think about the different kind of parents that you have in your unit. Sometimes a stress situation is imagine parents that are judging parents. They want everything organized, everything planned. So they come to the unit and see that yesterday the baby take bath at 7, today the baby are taking bath at 11, tomorrow they notice that they is taking bath at midnight, I don't know. This is a nightmare for that parent, you know? So we should explain that in our unit we have lack of staff or something that brings us to don't have at the same time some procedures or some care procedures. So we need to improve communication with that parents and tell them why we are not doing the way they like to, that we could do, or something like that. So if the nurse from Santa Maria said a few minutes ago about that mother, maybe she's a high person. Maybe she needs time, she needs to be alone, and we should give her time. Or maybe we can give her a card and tell her, look, we have this mother or these parents that also had twins and lost one of them. Maybe if you want to they will be able to talk with you when you want to, and then give a card with their mobile. Maybe we need to know, and we need to think in other forms to come to her or bring her to when she wants to. Okay, so we have parental support we are not in all units in Portugal yet, but we want this year 2020 cover all the units with groups of XSS parents volunteers. We have a website also. I will show you. This is our strategy for peer support groups. It's a psychologist that coordinates these groups. They have training. They have 16 hours of training, because the volunteers should be also prepared for the impact that is being with the parents again, because we left the unit sometimes 10 years ago or 5 years ago, and we should be prepared for the impact that is come back again to the unit and lead with the same situation that we experienced before, because we empathize with the more quickly, because we had the same situation or the similar situation as we are as the parents that we are helping. So this is very important also. And the psychologists and us help sometimes these volunteers after the sessions, we talk with them and to ask how it was, if something is, we should, if they need something also, if they need to talk, and because sometimes it's very, as you mentioned also as the nurse, the impact in the others is huge. So we have also our website, our Facebook page, and the high parents always goes to the website, never goes to the Facebook page, because, or sometimes they go there but they don't comment nothing, they don't send us a message in the FaceTime, in the Facebook page. They send us in an email, or they send us a message in our mobile. Never talk. And the high parents sometimes never go to the sessions in the hospitals because they don't want to be with the other parents. They prefer to be alone, you know? So this is very important, that we also provide some individual sessions if they want to, because the high needs this. We have also training and information for parents. These books we did these books with the help of the professionals. We work together. We have a protocol, a signed protocol from the first beginning. We have the doctors and nurses working with us also, and us working with them. This is very important for the quality of our work also. We have these books for fathers. They are in Portuguese, but the first one is for parents. The second one is for father. The third, in the bottom, is for siblings. The grandparents over there, the friends, because friends is an issue also. We had some friends that become very angry with parents because they don't want to talk during the hospitalization with them, and we create a book for them to tell them that the parents are not angry with them, but they need time. And we create a book for father, because father always saying in our sessions that they are forgotten. Because everyone is worried about the mother, and so we create a specialized one for the father. And the mother she's not jealous, because we don't know, we don't have one for the mother, but she's on the parents' book. Okay. She had training and information in we call survival, is sobreviver. Was with Mary Guglin. She was she gave training in kangaroo in units during 2014 and 15, I think it was. We hope that we could spread for the other units also, but it was an amazing training in 3 Portuguese units, 1 in the north and 2 in Lisbon. And we have psychological support for the psychologist that creates and coordinates the support volunteers also. We have a parent platform also with all this information for free that they could download. And I stop with this also again to remember that because this is a powerful quote, that don't forget that people forget what you said, people will forget what you did, but people will never forget what we make them feel. So, and I always finish my presentation with this. This is because a quote from Mother Teresa de Calcutta, Mother Teresa of Calcutta, and she says that my work is a drop in the ocean, but without it, the ocean is less bigger. So I believe on that. If we have all our drops, our help, the ocean will be bigger and bigger. And to finish, it's only 10 seconds, I think. I will have a video here from a Brazilian singer. I think is he's very well known, is Roberto Carlos. Do you, all of you, even the ones that are not Portuguese, have Portuguese language, you know? Roberto Carlos is the Brazilian, and he has a song that in the song the lyrics says, if I smile or if I cry or if I smile, the important is the experience that I live, that I is the feelings that I experienced. So I finish with that, okay? So thank you so much. Oh. Sorry. Could you put the video, please? Because the video was here. Oh, okay. Oh, sorry. I think they couldn't put the video. Yeah? Okay. Thank you.
Thank you so much. It's so important to have that parent perspective, and it's clear how passionate and engaged Paula is to bring resources to parents in Portugal. So thank you for what you do, Paula. And we're going to make a slight adjustment in our schedule at the moment. We're just going to save Mary's presentation and her little moment and bump it after lunch. And we're going to skip to a really exciting, did I see her? Exciting presentation by Nicole Bowens. And is she here? There she is. Wonderful. Her presentation is Quantum Caring in NHS and Grampan. Did I say that right? Nicole Bowen is a registered pediatric nurse who trained in Aberdeen, Scotland. From 1993 to 1996, she consolidated her training in Royal Aberdeen Children's Hospital, and she specialized in oncology and hematology for 15 years. But in 2008, she became a senior nurse and then was asked in 2013 to go to the neonatal unit as a nurse manager for 3 months. 6 years later, she's still there and has found her passion. Her particular interest in neonatal nursing is nurse education and family integrated care, including empowering families. Aberdeen Maternity Hospital is a teaching hospital, so she has close links with Robert Gordon's University in Aberdeen, Napier and the West of Scotland universities in Edinburgh and Glasgow, respectively. Nicole, with her team of 110 nurses, it's a big team, worked tirelessly to provide evidence-based nursing care whilst working within family integrated care model. Nicole puts her family, including her 2 dogs, travel and walking as her top 3 priorities whilst not working. She also hangs out on Twitter at Nicole Bowen, so check it out. Thank you. Enjoy.
Hi, thank you so much for asking me to speak. I just love that Aberdeen is actually mentioned in a lot of these countries because it is a tiny little city in the north of Scotland that not that many people have been to. So yeah, I said in my bio about me being most of my career in pediatrics, and certainly not with even in neonates because I was in hematology and oncology. But I think that when you think about the background and the parents that we all deal with, there is certain, transfer of knowledge. I very much have worked tirelessly within my own career progression regarding not being a neonatal nurse in a neonatal community. So I've had to work very, very hard at that. But last year I got my degree in neonatal nursing also. So I am a neonatal nurse manager now. So we'll just say that. I've got no disclosures or conflicts of interest to declare today, apart from, I suppose, we are in the middle of our trauma-informed journey in Aberdeen to be the first trauma-informed centre in the world. Not that big a disclosure, really. So what was our problem in Aberdeen? So we didn't have any kind of pain assessment tool validated. We didn't have anything written down. We eyeballed babies. We looked at babies. We did our best. but we certainly didn't have anything that we could audit or go back and see how we were doing with these babies. We gave pain relief, but again, not consistently. Some people gave sucrose, some people didn't. Some people gave a lot of sucrose, some people didn't. There was no consistency. Paracetamol was never really given. When I went from peds into neonates, I felt paracetamol was kind of the equivalent of what morphine would have been in a pediatric setting. So just to give a little bit of context. And also we now know that being in a neonatal unit is an adverse childhood event. I don't need to go over that again. And previous attempts had been made over the previous years in Aberdeen to roll out some kind of pain assessment tool, but had failed for all the reasons that everybody else has already said. Who did we call? So, I saw Mary first speak at the COIN conference in Vancouver in 2013-ish, I think. And that was me. I'd set out on my quest to find out how we could involve the parents, the families in Aberdeen in a better way. I remember on my first day, I stood in the middle of the unit, and I've already shared this story with some people amongst you. But I stood in the middle of the unit on the first day, absolutely pooping my pants. Excuse me. But yeah, stood there because, again, I knew nothing about these tiny babies. And I was standing with the senior charge nurse, and I was just thinking, oh my gosh, what will I ask? What will I ask? How many babies have we got? She said, 31. And I was like, 31? You could hear a pin drop in the middle of this unit. And this was only 6 years ago. And she said, yes, 31. And I said, but where are all the parents? I'm looking about, I couldn't see any heads in the nurseries. Oh, they don't come in till lunchtime because we have the ward round, and they're not allowed on the ward round. So they don't come in till 12, 1 o'clock. I nearly turned around at that point and just went back over to the children's hospital, which is in walking distance from the maternity hospital, but I didn't. I knew from that day that I had to find some courage to change what I found on day one in that neonatal unit. And Mary was really the next step in that course. I learned about family integrated care at COIN in Vancouver also, and there was 2 of us there. So we took back family integrated care and started to roll out family integrated care. But Mary was always in the back of my mind that we needed to do something more with Mary. So we did. This was our calling, I think, to be together. So this is a paragraph about what quantum caring is, what we planned to achieve in our 6 months that we had Mary, not in Aberdeen, but rolling with the programme in Aberdeen. So it was a case of we knew we wanted to educate our staff better. We knew we wanted to educate them and our parents and our clinicians about what we could do differently. And I think it was really important to realise that what was going on wasn't, nobody was being awful to those babies on purpose, nobody was being nasty to those babies. We just knew, a few of us only at this point, knew that we could do something differently. So this was the start of that. So how? So after we got the funding to go forward with the project, which the Friends of the Neonatal Unit, the charity attached to our unit, believed in us and believed in the application we made for funding, and they granted us that funding. So we were doing this very much jointly with our parental body and our charity attached to the unit. So leadership obviously is very, very important, and I can't overstress that. If you haven't got one person that is striving to do the best, to do what they think is right for the families and babies in that unit, you will come up and up and up against barriers, against people who just will not believe, the laggards, as we've already spoken about much today as well. So leadership, very, very important. Mary, also very, very important. She was here a week in the beginning, a week in the middle of the 6-month project, and then a week at the end. We put out a call for champions, and we've grappled with the name of champions over the 6 months, but that might be a North East Scotland thing, I think. I'm not actually from North East Scotland, so I can say that. I'm from Leeds originally. So champions really didn't bother me. And everybody knows PDSA cycles, plan, do, study, act. And we rolled and rolled and rolled, and we made tiny, tiny adjustments, PDSA'd, and then tried a different thing, tried another thing, and that is really the context, continuous PDSA cycles for many different members of the team. This wasn't one person in the team doing all the work. This was everybody had jobs to do from every call. So we had Zoom calls with Mary every 2 weeks, which for me, although most of the time I ran into the meetings sideways because obviously I always realized too late that they were on and normally eating my lunch, but we did it. We made it happen. And the beauty of Zoom calls, what we thought would be a block for us because our NHS security wouldn't allow us to do Zoom calls on their Wi-Fi, but that was actually a bit of a blessing because if people were on a day off, they could Zoom in from home as well, which they did. And our team really bought into the calls. It got very, it got embedded very, very quickly. And the Zoom calls were really, that was what held us to account. This wasn't me holding us to account. This was Mary holding us to account. So that for me was the cog that kept us going. Communication, I'm sure you can all understand why I've got that in there. This was the team. This was one of the first education sessions for staff. So Dr. Zeus, of course, in the background. We all know Mary loves Dr. Zeus. And a variety of staff. You can see most of them did actually come in on their days off. I did pay them for their time, but they were on a day off. So this was just one of the first. It was so exciting to finally be off the ground. So our results, what did we show? And you've probably all seen the posters outside, so they go into much more detail about the numbers and exactly what we collected data on. But these are very much an overview of our results. So staff knowledge specific to implications of toxic and traumatic stress improved over the 6 months. I do still get people asking me, what is all this about? That's okay. I'm now comfortable that I'm okay with that not everybody is at the same stage of the project. 2-person care, so this is the latest results. When I wrote the abstract, the 2-person care for needle stick procedures, the most recent data is 100% of those procedures were performed with 2 persons, and of that number, 15% is with a parent. I get goosebumps every time I read that out, because when we first started this, thank you. When we first started this, everybody, including me, said that would never happen. I thought that we'd try. What does try mean? I'm not too sure. But I never thought we'd get to that point. But we actually got to that point quite quickly. Because people realized the proof was in what we were doing. And independently, nurses, I cry a lot, so don't get upset if I cry. But independent nurses coming up to me and telling me, oh my God, the babies don't cry anymore, Nicole. And that, for me, even if that wasn't with a parent, that we are getting those results was absolutely phenomenal. And that was one of the biggest, I think, wake-up calls for me that we were getting somewhere. I know crying's only one aspect, but if you hear a baby crying in our unit now, we're all like, where's that baby? Where? And we're all, and we are led to that cry because it is actually quite unusual now that we hear a baby crying. So, our MPAS tool was adopted, and compliance with pain score documentations has improved by 70% over baseline. You'll remember baseline was 0 because we had no pain score tool out there. And we're still tweaking with our pain scoring in our special care unit. We're a big level 3 centre, 1,000 admissions a year. We've got SCBU, high dependency, and ITU. In ITU and HDU, so in critical care, the MPAS tool works beautifully. It's not working quite so well in our SCBU, and we feel we're missing capturing some data in SCBU, so we are still looking at that. And our pain project, I thought it would close at 6 months, but it carries on because we've still got bits to adjust. We've still got things that we want to do differently. So our conclusions: engaging staff and parents are absolutely key to large-scale change, and this was large-scale change. We sit at 90% occupancy, which is around 30 to 31 babies at any one time. Parents, and this feeds into Dita's work, parents were not traumatized by being the second person during painful procedures, and that validating that parent's role as a parent, as a safeguarder for their baby, that is really, me as a parent, my boy's 21 now, but I still like to keep him safe. That is one of my primary roles as a parent, as a mum, to keep that boy, young man, safe. So they expressed feelings of empowerment and role validation. There was some people that have their particular dislikes. We all know ROP. But the language that we use is so important for these families, and the families that have been through having to watch their own baby have an ROP will probably know that you've maybe had a nurse say to you, "Oh my God, it's eye day. If you want to stay, you can, but oh my God, it's horrific. It's awful. It's just, oh God, if that was my baby." On the reverse of that, it's eye exam day today. It's not the most pleasant thing, but your baby will really appreciate you being there. You don't have to look. We've worked around this, and we know ways that you don't have to see what's happening. You can be there, and be there for your baby is much different to my first expression. So we've certainly worked around things. Our ophthalmologists are coming along with us eventually. So we don't quite do ROP exam in skin to skin, but I think we might be there by the end of 2020, and that is certainly within our sights. Thank you so much for listening.
Wonderful, wonderful work in Aberdeen, right? Pretty cool. Okay, it's lunchtime, which is a great thing. We are just a tiny bit over, but we are going to stay on track with the schedule. So if you could please be back by 15 minutes after the hour, we will be able to resume according to the schedule on time so we can finish on time. So enjoy your lunch. It is in the same spot as yesterday. So over in the building on the right where the cafeteria is, or the small coffee shop. So that's where lunch is. Enjoy. We'll see you at 15:15.